Hi, everyone. I'm going to start a minute early just to give ju just to give full I guess to highlight something that's coming up. Our next webinar is going to be Dr. J. John Mann, MANN. He's a psychiatric researcher from Columbia, and it's on at noon on December 22nd. This is one of the most, I guess, recognized and published researchers on suicidality in the United States. So we're incredibly lucky to get him. So, but before we get into this, please consider setting your calendar for December 22nd. I, I've worked on suicide prevention at the highest levels, and he is as good as it gets for the United States and arguably for the world. So we're really excited to have him on December 22nd. And coming from a family that was affected by suicidality, it means a lot that he agreed to join us. Okay, so this is our welcome to the Montana Mental Health Sensing session. Matt Kuntz, I'm the executive director for NAMI Montana, and I am so excited for everyone for joining. We've got a great turnout today. Thanks to Tim Lewis, who has helped us with the IT as always and has done a great job. The reason why we are having this is because I was confused about our mental health system. We've had so many changes. We've had funding stream changes, technology changes, COVID-19 impacts, and it's really just created a big sense of confusion. And everyone I talked to had parts of the system that they knew and parts of the system that they didn't know. And there were changes that they were totally on top of, changes that they hadn't heard of yet. So that was our goal, was to try to see how can we get everybody to get a system-wide analysis and see what's going on from one corner of the Montana to another, from the largest hospitals down to brand new fledgling mental health centers. So we're really grateful to everybody that jumped on board. We've got an amazing group of presenters from across the state, and we are going to record this and share this with legislators, the new administration, and just everyday people to let them know what's going on right now on December 8th in our mental health system from around the state. So we are going to get started out with Zoe Bernard from the Addictive and Mental Disorders Division, and Megan Peel from the Children's Mental Health Bureau. And we are incredibly grateful to have them. Thank you, Zoe and Megan. And each presenter will have 12 minutes, and we will try to stay on track. We will have a break at 10:45 to 11. All right, Zoe and Megan, thank you for joining us.
Thank you very much, Matt, and thank you for the opportunity. So I assume that you can all see our screen, our slideshow. Great. Okay. First thing I wanted to do is place us where we are in terms of the super agency that is the Montana Department of Public Health and Human Services. And Megan and I are both in the Medicaid and Health Services branch. We both work directly for the Medicaid director, Marie Matthews. The administrator of the Developmental Services Division is Megan's supervisor, Rebecca DeCamera. And then I am just down from that in the Addictive and Mental Disorders Division. So we are part of Medicaid. Matt asked us to talk about some of the changes that have happened as a result of COVID-19. One of the big ones that many of you are aware of is we have a temporary suspension of face-to-face delivery requirements for some of the intensive behavioral health services, and allowance of audio only for some, for most outpatient services. We also temporarily, due to the COVID-19 pandemic, suspended prior authorization and continued stay for some Medicaid programs so that providers could focus on getting the services out to the people who need them. Megan?
Thanks, Zoe. Additionally, we made some changes to targeted case management to allow targeted case management to be provided by qualified mental health professionals whose primary responsibility is not delivery of targeted case management. We have administered millions of dollars in behavioral health grants that were designed to address losses in revenues due to COVID-19, and providers were eligible for their demonstrated losses up to 8% of their patient revenues. And we made some changes to youth CBPRS, which is community-based psychiatric rehabilitation services, to help support youth, really thinking about kids that may be living in a therapeutic group home during this time. So we are allowing group CBPRS to be provided while in a therapeutic group home, and extended some of the limits on that. One other that we don't have on here that we can add that I just thought of is some assistance for residential or congregate care settings for additional payment if they have a quarantined or isolated individual due to COVID-19 positive results or exposure. Okay, so the next slide. As Zoe said, I work within the Developmental Services Division. As the Children's Mental Health Bureau Chief, my role includes oversight of the Children's Mental Health Medicaid Benefit Plan, provider relations, utilization review, and then a lot of collaborations with other divisions and organizations that within the child serving systems. Additionally, our division, which is administered by Rebecca DeCamera, oversees the Developmental Disabilities Program, including the 0208 waiver and the Autism State Plan, and the Intensive Behavior Center, which was formerly known as MDC. And just a little bit of context, in state fiscal year 2020, we served just under 22,000 Montana youth with a budget of our expenditures of around $115 million. We've had several successes over the last couple years in the children's mental health system and bureau. One of them is we've been going through a systematic and collaborative program redesign of services within our continuum of care. So far, we've made some significant changes to targeted case management for youth with serious emotional disturbances and home support services. Included in that, we've really emphasized family engagement throughout that redesign. And we've also implemented a statewide standardized functional assessment tool that is used in targeted case management, will be used in home support services effective January 1st, and then is also planned to be used for Family First with CFSD. We've had several collaborations with other divisions and stakeholders that, we don't have a lot of time to go into it, but, we've worked a lot with OPI on some grants and social emotional learning projects, juvenile justice on some research projects for residential placements, and done some work with MapNet, which is a pediatric psychiatric consultation program. Okay, next slide. So moving forward, some of the things that I'm excited about working on. First, we're working on an independent evaluation of targeted case management. As I said, we significantly redesigned targeted case management and the program standards. So looking at that and to measure the efficacy of this redesign, we're partnering with the Center for Children, Families, and Workforce Development at the University of Montana to do an independent evaluation on these changes, which we are beginning work on now. We're also partnering with the center to distribute some grant funding to providers and others in the children's system that will help support transitions into adulthood and improved family engagement. Those RFP, the proposals are due on December 18th, and we will be administering the money in January. Our next big stakeholder group for the system redesign is comprehensive school and community treatment, and we plan to do that in May. And then just our continued work on Family First Prevention Services Act within the department.
Okay, so as you all know, I oversee both adult mental health and youth and adult substance use disorder treatment services. Also am playing a significant role in collaboration with Carl Roston in working on our suicide prevention program for the state of Montana. And our continuum of care includes the full array from prevention all the way to recovery. As I'm going to talk about, we're also working on the crisis system collaboratively at this point in time. I oversee 3 facilities: the Montana State Hospital, the Montana Mental Health Nursing Care Center in Lewistown, and the Montana Chemical Dependency Center. What have we done besides changes due to COVID? I am proud to say that in the last year, we doubled the capacity of the home and community-based services waiver for adults with severe and disabling mental illness. The waiver is now available statewide with individualized services to help people remain in their homes and their communities wherever possible. We also worked collaboratively with providers to develop additions to Montana's program for assertive community treatment, which is an evidence-based, well-respected, well-established national model. At this point in time, we are going through a fidelity assessment of all the existing assertive community treatment teams in Montana, and we have revised the rules to make it more possible for people to both provide and receive services in the more remote parts of Montana. So we're very excited to see those changes come to fruition. On the substance use disorder side, we worked with providers to develop an intensive outpatient treatment services bundle. For those of you who know the American Society of Addiction Medicine levels, that's ASAM 2.1. That model has been, I would say, almost explosive in terms of its acceptance across the state and has been very helpful for those who are involved in drug court. We also have been using our federal funds to develop a medication-assisted treatment bundle. And I'm pleased to say that the opiate dollars that are coming down, we can now use them in this coming federal fiscal year, which started about a month ago, to start to provide education and evidence-based practices related to stimulant use disorder, which is the class of illness that includes methamphetamine use. So we will be rolling out the trust model, which is a revision and update to the matrix model, which was previously the most accepted form of stimulant use disorder treatment. Really, I would say the last 3 years have been about figuring out how to take advantage of Medicaid expansion to make sure that people in Montana get the services that they need, where and when. And that has allowed us to take what we're doing and expand it outwards and start to focus on other things. So our next steps will be, number 1, suicide prevention, which is a significant issue in the state of Montana, as I'm sure that you are all aware. I spent most of the last year working with consultants and a stakeholder group to revise our suicide prevention strategic plan and really modernize it. And now we're going to implement that strategic plan. That's our next step. In addition to that, COVID-19 has given us a wonderful opportunity to work on the Crisis Now model in Montana, primarily through the County Tribal Matching Grant Program, which was originally developed as a way to keep people out of Montana State Hospital and other secure placements whenever possible, although there is still room. There's still a place for psychiatric beds. They're needed sometimes. But to make sure that those are there for the people who need them when they need them, and to make sure that resources are used wisely, we are going to be continuing to work on the Crisis Now model in Montana. I would say probably for the next several years. There, Matt, we made it in our 12 minutes.
That was perfect. So Zoe and Megan, thank you so much. We're waiting for our next panelist to log on. Zoe, can you tell us a little bit more about that Crisis Now model?
Sure. The Crisis Now model is a model that was developed with collaboration between NRI, the National Council, SAMHSA, and NASHPD, which is my professional organization. So all the people who are really in the know about what is needed in terms of crisis. It has 3 major components, which include mobile crisis units, where those can be used, dedicated call centers, and the use of other appropriate community-based services. We are starting to see some communities in Montana take advantage of the county and tribal matching grant to implement mobile crisis units. Some of the communities have done so through the bill that went through last session, and others have found a way to just make use of the county tribal matching grants. So I think that in terms of gathering data, we're going to be able to know, Matt, within the next year to 18 months, whether mobile crisis units are a successful model in Montana.
Oh, excellent. Thank you so much. So it was really a great way to start our sensing session. And just as a heads up to everybody out there, we don't have a ton of time with this because we're trying to get everybody, like 18 different organizations at once. So thank you so much. And please continue to pester Zoe and Megan with questions afterwards. Next
Absolutely.
up.
Thanks, Matt.
All right.
Thanks.
Thank you. Next up, we have Mary Windector, the Executive Director of the Behavioral Health Alliance of Montana. And Mary represents a lot of different organizations that are doing great work across the state of Montana. And we're delighted to have her and the insights from her members.
Thanks so much, Matt. Happy to be here. I'm really excited to work with you. I'm wondering if I can present a brief PowerPoint, if you can give me.
Absolutely. Tim, can you make sure that she can do the share screen? And Mary, you might have to go down there. Yep, there.
There we go.
All right.
Okay, so I just want to kind of give everybody an overview of who we are. Sorry, just want a slideshow and from the beginning. Okay, can you all see that?
Yep.
Good. I don't want subtitles. Okay, got it. There we go. Okay, so how do I shut off subtitles now? Are you guys seeing the subtitles?
Yeah, I wouldn't worry about it.
Okay. All right, so
cool feature though.
Well, that's great for the ADA group. We were formed in 2017 by the Montana Healthcare Foundation, which is a conversion foundation that came out of Blue Cross Blue Shield. And we provide advocacy for behavioral health providers. We have all behavioral health providers who treat adult, children, mental health, substance use disorder, or tribal behavioral health. And we have about 35 members now across the state. So it's really gone well, and we've been excited to work with everyone. One of the main things that comes out every time we meet is we're failing our children. The number of Montana children in foster care has more than doubled since 2011. It has leveled off in the last couple of years, and we've worked really hard to try and get programs in place to reinstate those prevention programs. Out of the 3,200 in foster care, 64% were removed for reasons of parental substance use. So it's even more important to focus on the family so we can keep those families together with preventive programs. Among the Medicaid patients, the percentage of infants with perinatal drug exposure has increased dramatically over the last several years. And we do have a Meadowlark initiative that Montana Healthcare Foundation has run to really work with those moms and kids for prevention during pregnancy. The National Survey of Children's Health reports that Montana has among the highest reported adverse children experiences. Those are ACE scores that I'm sure most of you are familiar with. And 52% of Montana children aged 0 to 17 report at least one ACE, with 17 having 3 or more. This is a map that shows the excessive drinking in Montana, and the darker the color on the county, the higher it is over the national average. These counties that have no coloring are not because they're doing great, it's because they didn't submit data. My guess is a lot of these in the central eastern part of the state are very high for excessive drinking, particularly binge drinking in younger ages. Again, the overdose deaths involving opioids, you can see here any opioid and then where they look for others down here in the synthetic drugs. But really opioids is not the issue across Montana, it's meth and other stimulant disorders. So if you look here at the meth rate, you can see it's very, very high. So that's why working with AMDD, we've started a stimulant use disorder kind of task force that we're working towards and looking to do a lot of training with providers out there for stimulant use disorder. That's one of the things Zoe has been pushing with Montana Primary Care Association and us. Suicide, again, we're, I think, third right now nationally, less because we really improved than because other states got worse. But again, a high rate of suicides, particularly in the Native American and in the male populations across the way, and a really high rate of middle-aged white males in the rural communities. Like Beaverhead County has a really high statistic for middle-aged white males. And again, very few services available after the budget cuts in a lot of those counties. So we're having discussions with the counties for how we can reinstate services in many of those. Alcohol continues to be a major factor in the suicide rate. You can see here that 42% of the suicides had a toxicology report showing alcohol. So that's a big factor combined. Alcohol continues to be one of the largest issues in Montana, is the high rates of drinking. By means, 63% are by firearm. So it's something we need to work on. The state has implemented a suicide prevention task force, really looking at that state leadership to develop a comprehensive program. Every county sort of has their own programs, and many of them were evidence-based. Many of them were sort of put together by volunteers, which is great, but not always the safest way to address suicide. So the state has stepped up with creating that task force for us to plan. One of the big issues is the aging population, both because it's going to create a boom for clients for behavioral health, and it's also going to reduce the workforce that's available for behavioral health. So right now in 2025, over 65 will be the largest demographic in Montana. And this year, by 2020, ages 20 through 59 began declining as the birth rates are flat. And what we're saying for the in-migration into Montana is usually a retirement age. They're retiring to Montana, so it's not helping our workforce, and it is increasing the number of clients we need to serve. So this is a huge issue. We've been talking about it for 15 years of how we're going to treat all the people who will need it. We talked about the budget cuts. We've made a lot of improvement on those. We've worked really hard with both Children's Mental Health Bureau and AMDD. So you can see where the cuts, primarily the cuts were to behavioral health providers. And then on the right, where we've worked to create sustainable programming in all of those. This one is actually, there's a task force this is an old slide, but the task force has actually just been completed. And the rule is out for public comment until the 12th. Megan?
It actually closed on Friday.
Oh, okay, it closed
Yeah.
on Friday. There are lots of rules out there. I'm never sure where we are on those, but it closed for that. And then some of the other cuts that we're looking at for just trying to replace. So we've spent the last few years since 2017 and 18 really working with DPHHS to try and put in place sustainable programs that won't get cut again. And going into the legislature, of course, we'll be looking at that again. One of the unusual kind of problems that came out of the cuts where we saw involuntary commitments go up in 2017 versus 2018, where Missoula County alone saw almost a 30% of involuntary commitment increase. So what we did was shift the problem from prevention and sort of on the front end over to diversion, involuntary commitment, jail, those sorts of things. And we really saw the counties grappling with handling those cuts. So we've worked hard to get the funding back with the crisis intervention teams and all of those sorts of things into the counties to help them with that. We did have some legislative successes in 2019. We got an additional 1.5 allocated for substance use treatment, and that largely went to improving the system around intensive outpatient programming for substance use disorder, something we worked on with AMDD a year and a half ago, I think it was, Zoe, and put that in place. And that's been a very successful program, being able to treat people outside of a residential acute facility in really that intensive program. And then the 3.5 million was allocated for targeted case management, and we saw improved rates and sustainable funding for children's targeted case management that went into effect last summer. So really happy to see that come back and be able to help. And then peer support specialists, an important part of our workforce as we move forward, is now reimbursed by Medicaid. So we were really happy to see that happen. Our platform session for the 2021 session is really continue our work around systems of care and continuums of care. We've done a lot of work with AMDD around the adult continuum of care, and we want to continue that work. We had comprehensive healthcare forums in the end of April for specifically around behavioral health, the first time that's ever been done. We were able to listen to all of the state offices, the candidates who were able to talk about where they stood on behavioral health. We're also looking at some sort of sustainable funding for behavioral health. Not really sure yet what that looks like. Obviously, the marijuana recreational tax is out there. Montana Budget and Policy Center has done a lot of work around sunsetting tax credits that may no longer be applicable. So there's a few different things out there. And then, of course, defending Medicaid expansion, if there's any move to somehow limit that, that's very, very important for behavioral health, especially substance use disorder. We've seen a lot of people helped in behavioral health with substance use since the Medicaid expansion. COVID-19 support, we've had just as crazy as a year as of everyone else. We were able to get PPE either donated, and then AMDD and the state stepped up and reimbursed our PPE costs, which was tremendously helpful. We have a continual COVID meeting with the DPHHS every other week. It's segued into other things in COVID now, but we do still continue that meeting, which has been really valuable for looking at different federal and state funding that's available to shore up the providers while they're working on that. We're looking at how to continue the expansion of telehealth and telephone services after the emergency. That's something that we had to ramp up really quickly. And it's very important that we now are able to provide that. I just saw yesterday, Senator Tester has secured money to enhance broadband coverage across the state. And that's hugely important because in places like Beaverhead County, if you're outside of Dillon, you have no or little or spotty broadband coverage. So that's super important as we look at implementing telehealth, that we have that broadband support. And then the 1.2 billion that came to the state, there was a lot of COVID relief funding for behavioral health agencies and nonprofits in that, and a tremendous help for just basically keeping our doors open. So the state's been very, very supportive. They just initiated a kind of quarantine and isolation funding payments for behavioral health, or actually assisted living as well, and some other agencies, especially for congregate care, where the agency had to put people in the home into isolation, and then increase staffing and all of the other costs that came with that. So the states implemented that funding, and again, we're incredibly appreciative for all of their help. Takeaways, this is my depressing slide. Montana's getting older, dying sooner, suffering from more self-inflicted diseases, and committing suicide more than people in most other states. Our children are experiencing more mental illness, and fewer resources are available for the birth and foster families. Behavioral health services overall are on a limited basis and really available in the urban areas primarily. We're reimbursed on many programs at a rate below the cost of providing the services, and that's made recruiting providers extremely difficult. We're losing providers who want to work with the severely mentally ill or severe emotional disturbance children and adults to people who want to work in a less acute population, because they can make a lot of money more than we can pay. So that's been a huge factor with the transition of people from working in the very acute up to working in the less acute systems like the community health centers or the hospitals. Our Native American population dies one full generation earlier than whites. That's been true for quite a while, and it's just a shocking statistic that I don't think a lot of people know across the state. We've started implementing evidence-based and outcome-based programs because we feel like that's really important to improve the quality of the services that are offered. And so as an organization, we've worked really hard to implement that. And we're working on a database that will track quality indicators so that we have that available for our agencies to be able to plan and create better programming with that quality indicator in place. And also the state system, we've started working on this. We're creating a continuum of care rather than working in silos. Again, this is an older slide, but really creating that continuum so that families aren't falling into the cracks between the silos of care. So they're not working with, just children's and family services, and then they go to children's mental health or vice versa. And there's a lot of difficulty with navigating the system, especially for families who are in crisis. So we worked real hard with the state to try and improve that continuum of care. And
thank you. No, I'm sorry. Thank you so much. That was a wonderful presentation. We're under a really tight timeline. It was really great. Please continue to ask Mary and the Behavioral Health Alliance of Montana for guidance and questions ongoing. Next up, we have Brad Hickok from CIT Montana. And CIT Montana is a great organization that has helped expand the CIT program. And I can say we actually tell people to ask for CIT trained officers because it does lead to better outcomes, and it's been a wonderful partnership with mental health providers, families, and others from across the state. Brad, thank you so much for joining us today.
Yeah, I appreciate the invite, Matt. And I'll try and run through just kind of a brief history of CIT Montana, and then some of the things that we've had to overcome or will have to overcome here in the coming years. First of all, I'm Brad. I'm a law enforcement officer here in Gallatin County. I work for the sheriff's office. I've been here for 19 and a half years now, going on 20. And this is my first, I haven't even quite been my first full year at CIT. I first went through the academy back in 5th Academy, and we are now going to be hosting our 15th, I think, Academy here in February. So it's been quite some time. So as far as the inception of CIT, the program came out of Memphis in the late 80s as a result of public outcry and a call for less heavy-handed approach when it came to law enforcement and dealing with folks with lived experience and families of folks with lived experience with mental illness, and also some serious issues with disparities and racial tensions, which it's hard not to draw a parallel to things that are going on nowadays in law enforcement, and particular with racial disparities and mental illness and how we handle those situations, and a push to decriminalize mental illness and to find better ways of resourcing folks that struggle in crisis. So out of that issue, in particular in the 80s in Memphis, they put together a panel of mental health experts that brought in diversity of both operators in the field, first responders, folks that were therapists, that were medical providers. NAMI was instrumental in bringing experience from folks that struggle with mental illness, who had experienced crises and where they could learn from it, and law enforcement learned the ways that they were handling the situation and how the public would rather that they were handled. And that kind of culminated back in the late 80s. It's been developed since then, and we first brought it to Montana here about 15 years ago. Our model has evolved to some degree, but still adheres to a 40-hour training model that we incorporate in our academy that we put on. The focus of that academy obviously is to be the initial training for not only first responders, like law enforcement, firefighters, but nursing staff, to incorporate and have input from people throughout an entire community. And then further on down the line with the county attorney's office, with health care providers, that care coordinators that might help with long-term care, but where law enforcement deals with folks with mental illness, it's almost like a first aid for crisis, and then resourcing to that point. And that's how we've tried to build that up in Montana. Some of the, well, let's step back here. CIT, what it stands for is Crisis Intervention Team. A lot of that is lost in what people's understanding of it is, and it's treated as, or is thought of as, a training. And training is a big part of it with the 40-hour academy, but the team concept is what really keeps communities together, in using local resources and stakeholders from particular communities that want to have a team, from law enforcement, county attorneys' offices, mental health providers, families and persons with lived experience, medical providers, NAMI, and many others, with the goal in mind of helping individuals that are struggling with mental illness at the point of crisis, and routing them to appropriate care, rather than putting them into the criminal justice system due to illness-related behaviors. That behaviors that without that mental health component would be seen as criminal, that are just symptomatic of the illness that they're struggling with at the time. Here in Montana, since its start, we've conducted a 40-hour education academy that's presented by, as I said, local resources. Recognition of symptoms is a big piece of that academy. Familiarization with local resources, and interaction and empathy building with folks that struggle with mental illness. Communication skills has also kind of morphed into a main focus of what we do in our academies, and exactly how we conduct that using an adult learning model to help educate folks, particular to my profession, and also throughout the community, but with first response and law enforcement and firefighters and EMT, with how to communicate with a person that's struggling and in crisis and dealing with mental illness that might be different from what they experience with someone that's having rational thoughts and is able to communicate on the same level. It makes those officers or the folks in the class able to ask difficult questions and de-escalate situations in a manner that they might not have been comfortable in doing so. As we know, is one of the best ways to be direct and to listen more than you speak. And that's what we train throughout the academy. But more than just the academy, it's that cohesive teamwork throughout the year. An academy is 1 week a year in a given community, and by coming together in person, we can put a face to the names and the organizations that we might be in contact with or can help resource. So what it entails, or what's necessary, and some of the things that are difficult about putting together teams or maintaining teams here in Montana, are that there are law enforcement and mental health lead coordinators that help keep the whole thing running and together, and keep all the other partnerships intact and the stakeholders at the table. There needs to be a facility or access to a facility that can provide at least 72-hour hold. That's one of the big issues we've come across in Montana, particular to rural environments or smaller towns that don't have one and have had to use a similar model based on like a hub of having a local or a regional facility that we can utilize, or a smaller town can utilize, that borders a larger city like Billings or Bozeman or Missoula or something like that. It also is very paramount that there's buy-in from administrators of agencies such as the sheriff's office or a police agency, as well as your mental health provider, your medical health provider in town. Bozeman Health would be ours. And all on the same page and getting together to talk through and mitigate any issues that come up with handoffs if you are utilizing a hospital instead of a specific facility for a 72-hour hold. Other organizations, and sorry, that's just a very brief rundown on the academy and how those relationships work. Other things that have come in extremely handy, and I had heard mentioned earlier, utilizing grant dollars to fund alternative methods for dealing with crisis in the community, as we see the instances of those crises or involuntary commitment hearings going up. Are mobile crisis units that have come up or been utilized here in Missoula and in Lewis and Clark County, I believe. We have a co-response model here where we have therapists working in conjunction with our law enforcement officers and going out into the field and treating folks in community, and most often leaving them in community with resources and being that person that can take a handoff when the situation doesn't call for law enforcement. PAC team that has been up and running in this and other communities and is continuing to put on client lists so that they can deal with the long-term treatment of individuals, and it's not just a once and done, so that there's fewer interactions with law enforcement. Those interactions are easier when both the consumer knows what to expect and has been involved in the system, and our law enforcement or our other first responders are trained in crisis intervention. Check how we're doing for time here. I know I don't have much left, so I'll talk about a couple of the issues that we've had or coming to this year, particular to COVID and otherwise, or stemming from it. Our academy is 40 hours of in-person training, and we try to push for a class size between 25 and 40 participants. This year, they have pretty much completely shut down due to COVID-19. It's paramount that they take place in person. We can do some things using our learning management site, but CIT International does not endorse a virtual model, and I concur due to what you lose on a Zoom meeting. We can't get that empathetic understanding, that buy-in from our individual participants at the same level as we can with in-person. And the learning model is not built to do over Zoom. We use small groups that break out of those participants and coach repetitions that you just couldn't take full advantage of in this kind of a format. And consumer contact is vital. We have not had an academy since February of this past year, and hopefully we'll have one February of this year here in Gallatin County. But some of the things that we're going to have to overcome regarding consumer contact are the inability to participate in panels and tour a facility at Warm Springs because of concerns of infecting folks over there at the state hospital with COVID-19. Or here at our drop-in center or the Hope House here locally. Also, broadly, communities lack understanding of what CIT really stands for. I'm getting the finger from Matt, so just cut me off when need be. I'll hit one or two more if that's okay. Broadly, communities struggle with lack of understanding. They'll get grant dollars and think that they can put on a training and be done. This is a team. This is something that you bring in a community and sustain as a community and present as a local community with their resources. Increase in need, coinciding with a decrease in ability to have that one-on-one interaction. And for outreach with travel, I would travel and present to rural communities, local or Montana tribes that have all but shut down because of the pandemic. Things like Zoom have been very helpful in outreach and being able to do quick seminars and things like this. But those are some of the struggles that we've dealt with to this point. So I'll try and keep it inside my 15 minutes. I think I'm right at the buzzer, Matt.
Perfect. Thank you so much, Brad. And they do have a bill going to the legislature to help provide funding from Representative Barry Usher.
That's something that we're working right now on in defining that language, where exactly we'd like to see it, to make sure and include all the important stakeholders in that. So it's not just coming in a linear fashion, so that everyone across the board, mental health and otherwise, has a say in that. So that it's steered in the appropriate direction to overcome that sort of grant funding hump of, are the dollars going to go away? We'd like to see it hard funding in the state of Montana and in perpetuity.
Excellent. Well, thank you so much, Brad. We really appreciate it, and for everything that your officers do for our people just every day. Thank you.
Yeah, thanks for the invite, Matt. Appreciate it.
All right. Next up, we have Cindy Sturgar from the Montana Primary Care Association. Cindy's been an amazing healthcare leader in our state for years, and it's been a delight for us to partner with us. So, ladies and gentlemen, Cindy Sturgar, great background.
Thanks, Matt. And Brad, I love what you guys do. And we've tried to send medical providers, but they cannot get off work for 40 hours a week. But we love it, and we are really supportive. So hopefully that funding gets stabilized. We think it's incredibly powerful to have that community partner in all of our places. Again, I'm Cindy Sturgar, the CEO of the Montana Primary Care Association. We're an association of primary care providers, and at the moment we have 18 members, mostly community health centers, federally qualified community health centers, and urban Indian centers. So I'm going to share my screen so you can see where they are. Some of you are familiar with us and some of you aren't. That's where we are. We're all across the state of Montana. Not up here in this northeast corner. It seems like that just hasn't had an opportunity for us, that they've been able to do that themselves. But our whole goal and our mission is to promote integrated primary health care to achieve health and well-being for Montana's most vulnerable populations. And we are committed to equity in Montana, meaning that everyone should have the opportunity, the same opportunity to be healthy. And we do our work, of course, like you, through collaboration with integrity and with an eye to innovation. So our main work today as MPCA is to make sure we're working with our partners. So it was great to hear Mary present from BAM. We do a lot of work with Mary, especially around substance use disorder work and mental health work. So our centers located throughout Montana serve over 120,000 patients every year. How we do that is we do it through primary care, which is usually considered medical care to someone on the street. We do it through integrated behavioral health, which means we have licensed therapists, licensed substance use disorder counselors. We have care managers and case managers that work with the primary care team and often work with the dental or oral health team to make sure when people come to see us and they talk about everything going on, that we can screen and identify if there is a behavioral health issue, a substance use issue. And so at that time, we deliver that care to them. That care may mean that we bridge to more intensive care if that partner exists in our community. So we do a lot of work in the behavioral health arena. We do a lot of work in oral health. So dental services are a big thing that we do. And then we also have pharmacies. And in today's world, clinical pharmacy services are when pharmacists work with the patient, especially those that are very ill and on lots of medication, and or are using psychotropic meds, and or using Suboxone or some other medication. Those pharmacists help the patient understand how that treatment should work and ensures that that patient isn't over-medicated or under-medicated. So it's a really significant service that is provided for very complicated patients. So in all those arenas, we work with partners. And as you know, in rural Montana, partners are the law enforcement, partners are the firefighters, partners are the local hospital, the private therapists, the private psychiatrists, if we have them. So we do that kind of work all the time. We've been in Montana for over 50 years. Our first community health center was really Farm Workers, which has clinics all throughout the state and has mobile clinics, and especially during harvesting time. Sugar beets, the cherries, they have permanent clinics in Lolo, in Dillon, Billings, and up in the northeast corner. So those are those little orange buttons. I think we often forget about them, but there's this undercurrent of work that always is happening there. Some of the questions: what has changed in our organization or constituents since COVID-19? I think, like most of you, it has absolutely impacted every single person in Montana. What happened to community health centers is the first patient from COVID who died in Kalispell was a patient of the Libby Community Health Center, Northwest. And that patient called his doctor, who was at the clinic, and he was quite sick. She took care of him, got him into the hospital in Libby, and shipped him to Kalispell, where he later died. He was the first COVID death in Montana. Patients and people seek care most often at the primary care setting. The second group of folks in COVID died in Shelby and the nursing home, and those were the Shelby Marias Community Health Center patients. So those doctors were the first to assist the first patient who died in the hospital. Exposure happened up there, and a third of the medical practice. This was in April. A third of those folks became COVID positive. So it has dramatically impacted both the patient population in community health centers as well as the workforce. As all of us know, it's ongoing. This is a roller coaster effect. And so sometimes COVID seems to be lulling, and then other times we're at our peak. Yesterday in Montana, we tested, community health centers tested at some of our big centers, many, many positives. We are now seeing the second surge coming from Thanksgiving, and COVID is alive and well in Montana right now. So we experienced it both with our patients and with our workforce. What we did then with MPCA is we worked with DPHHS specifically in testing, a testing contract to help the state get tests out and get those started in the communities. We have Alluvian up in Great Falls, probably still today tests about 500 community members a day. Testing has moved to symptomatic patients. Butte is a big testing site, and of course Billings, Yellowstone County is quite high with cases of COVID. So we became a testing site. Pureview in Helena was the first community health center to do a drive-through testing with the support of DPHHS. So we've continued to partner as close as we can with the state of Montana to help protect the citizens of Montana. I think as Mary talked about, equity is a major issue. She showed the prevalence with Native Americans, and we're seeing the same thing with COVID. Native Americans are about 6 to 7% of the population, but their rate of cases is substantially higher than the rest of the population. They're at about 13 to 16% of COVID positive, higher than anyone else, and 26% of all deaths. So it's really impacted our Native American population in a way that is not beneficial. Our health center in Hardin, that staff has probably attended more funerals this past 8 months than they have in the past 10 years. It's been a devastating disease across the state. Our health centers have been there, they continue to be there. What they all did, similar to other primary care centers and many of your mental health centers and substance use centers, is they had to close their doors and we went almost 100% telehealth in March, April, and May with very small access points for respiratory clinics because of PPE. And so in the beginning, we continued to do that. We engaged in telehealth. And then at MPCA, we also engaged in a public education campaign to try to keep people apprised of what was going on. So that continues today. We're still working on that with the state with vaccinations. As all of you know, vaccines is going to be another roller coaster for our people in the state. The hospitals will get the first vaccines. We are in the first tier, but we will wait to get the Moderna vaccine, which will come out the next week. And then, as you know, everyone's working on, will people get vaccinated? So we're working on that with messaging as well. I think our biggest issue is that we believe that stigma is such a big piece of this. If people don't seek care because of stigma, that's a problem. We believe primary care everywhere needs to be integrated, educated, and trained around behavioral health and mental health, because the access point for people, they often come there because the stigma isn't there. They can just say to their friends and their family, I'm going to the doctor. And that allows them access. So we, as the MPCA, have a number of contracts in training. We work with AMDD and Mary's group specifically around substance use disorder, making sure we get our providers waived in being able to treat with medication-assisted treatment. We support with more training around opioid use disorders, and we continue that work throughout the state. Again, partnerships is big for us, so we really appreciate being able to come today. And I'll give you a few minutes to breathe, Matt, in between things, so I'll tie it up. Thanks, everyone.
Awesome. Thank you so much, Cindy. That was great. I know my wife works at a primary care association, and seeing what you've done for all of their clinics has really been valuable. And watching that in the past 9 months has been astonishing in particular. So thank you. All right. And we're going to transition next to Matt Buney from Aware. Matt has taken over Aware, he'll say, I think it's been 2 years, and it's been it's a wonderful organization, and we're so excited to have Matt share with us what they're seeing, their challenges, and what they're excited about for the future.
Well, thanks for having me. I hope you can hear me okay. I got to thank whoever it was that put me behind Cindy. That's a tough act to follow. Again, as Matt said, my name is, as Mr. Kuntz said, my name is Matt Buney. I have a history prior to working for Aware of working with the state, working in the governor's office, governor's budget office, and then I spent some time over at DPHHS, learning a lot. I've been with Aware for about 10 years. Last 2 years, as Matt said, as CEO. Again, thanks for having me here. I'm gonna try to pull up a PowerPoint, so bear with me. Can everybody see that? Okay. So with Aware is based in Anaconda, Montana, but we provide services across the state. I've been asked today to talk about the impact of COVID and really what Aware does across the state with behavioral health services. Our mission is to help people live as independently as possible. Again, we're across the state. We've got offices in most of the major towns of Montana. We've got about 800 staff serving about 5,000 people. We say all 56 counties. Most of that reach geographically is through case management. And again, based in most of those major cities of Montana. Services that we offer. Aware offers residential services. We try to ensure that people with mental health or developmental disabilities are able to live in a home of their choice and receive day-to-day support that they need. We have about 40 group homes. We serve kids and adults really across the spectrum of mental health and developmental disabilities. We offer vocational supports. We help adults with disabilities find fulfilling employment, whether it's in an Aware work program or with businesses in the communities. We also support children age 0 to 5 and their families through early childhood programs in Billings, Bozeman, Butte, and Helena. These are programs such as Head Start, Early Head Start, child care partnerships, and home visitation programs. We also promote interdependence of clients with their communities through services like psychiatry, outpatient therapy, mostly mental health outpatient therapy, school-based mental health supports, and targeted case management. We serve a large population of Montanans, really of all ages, with autism, with services steeped in applied behavior analysis, ABA. We're also licensed to provide substance use treatment, which is braided into many of those other Aware services I've described. We also, with Aware's Child Advocacy Center, this is in Helena, we partner with Helena Tri-County area law enforcement to perform forensic interviews of children that have reported allegations of abuse or neglect. It's a great service to our community, although it is sad that there are an abundance of cases, and we see an increasing number of those cases with the pandemic. So what are the benefits of these community-based services? Along with other community-based behavioral health providers, to point out, Aware is a member of BAM. Mary Windecker described what Aware's priorities are before. Aware is a member of that association. So along with those other community-based behavioral health providers, Aware serves people and family with intensive needs, chronic needs, who otherwise would be mandated to receive higher and more costly levels of care. For example, we provide safe and loving childcare classrooms for infants and toddlers. We provide intensive in-home mental health therapy, and we teach families and guardians how to effectively parent. Kids in these services are at risk of involvement with CPS, foster care system, or involvement with law enforcement. We provide intensive therapeutic group homes for kids with serious emotional disturbance that have experienced removal from their natural homes or It's also for kids that are returning from out-of-state placements or for kids that are stepping down from psychiatric residential treatment facilities. I think you'll hear later from Craig with Showed Air. Our wraparound services are holistic and strength-based. We try to help our clients really build upon their strengths and find their passions. Our services are upstream. We try to prevent crises, and we try to divert from involvement with law enforcement, in people going to the hospital, behavioral health units. We try to divert from correctional facilities so that our clients and their families really can be and continue to be productive members of their communities. We think our services are efficient. Our staff really are very good at serving our mission. We save the state money. We contribute to boosting our economy. Aware alone, over the last 10 years, has spent over $300 million with local vendors, and our main cost is employees. We employ a lot of people. Again, to this day, about 800. Also, by taking the role of serving people with intensive and chronic needs, we allow their parents and guardians and family members to continue to be productive members of their communities. So with COVID-19, what has changed? A lot. I think some of the biggest impacts immediately were along with school closures and the stay-at-home order. They're most immediate and drastic in March. These, of course, have continued to this day with intermittent closures, school closures in various districts. During the school closures, kids we serve in therapeutic group homes remain at the group homes with remote learning. This requires staffing during those school hours that wasn't required prior to COVID. Not only this, but some of our employees also have their own children to attend to at their own homes. This is not unique to Aware. This is similar with many other providers. So even though we have a need for more staff, we have less staff to deliver this care. School closures have also impacted school-based mental health services and our early Head Start classrooms. Similar to teachers, our employees, including the mental health professionals, are trying to meet kids' needs remotely. Even with the fears of contracting and spreading COVID, with unavailable staff due to COVID exposures, quarantines, and an extremely high rate of position vacancies, we still have many dedicated and committed people willing to continue services. Aware is fortunate we haven't had to decrease our capacity or implement layoffs or furloughs. Many of our remaining staff are volunteering for extended or extra shifts within group homes due to quarantines and isolations. This is great in that it helps us continue to deliver services, but it leads to burnout and costs an outrageous amount in overtime. Our staff are trying to evolve care delivery to support people we serve, really kind of pushing the boundaries of creativity to keep things fun and interesting, and really to stay engaged with our clients. Technology, you've heard before, technology is more important for psychiatry, mental health therapy, and case management. We're using ever more telehealth as what we're utilizing for more service provision. I really sincerely thank DPHHS and other insurers for recognizing the need to allow this form of service delivery. These changes have not decreased our revenues much, but they have significantly increased our costs for staff, overtime, PPE, technology. Since March 2020, we've experienced approximately about $2 million in increased costs for the same level of services. What else has changed for us? Well, many people are experiencing forms of trauma, which is not unique to Aware. It's not unique to our clients or staff. Mental health needs of our communities have increased. Anxiety, stress, depression have all increased with the pandemic. Our staff are also greatly impacted by these influences on mental health. They're tired, overwhelmed, trying to navigate challenges within their own personal and family lives while still trying to be present and stable for our clients. Sadly, we're also seeing increased cases of abuse and neglect. Threats and opportunities. Concerns, like everybody else, health and safety. Cindy described this, COVID is alive and well. For every person we serve, our employees and their families, we're worried about health and safety. We can't do our jobs without appropriate staffing ratios. It's become increasingly difficult to hire and maintain an adequate workforce. To fill vacancies with qualified staff, we compete with unemployment insurance, and really we compete with higher service rates being paid to facility-based and higher levels of care like FQHCs in hospitals. And they're really for services delivered by the same credentialed staff that we're competing to employ in mental health services, specifically LCPCs, LCSWs. I also worry about adequate and sustainable funding for this system of care. I believe in what we do, I believe in our mission, and I worry about that sustainable funding because I do think we're very good at what we do. What are we excited about? There's still a need for face-to-face care. I think it was Brad with CIT that described that need and just that difference of in-person care versus telehealth. So there's still a need for that, but there's really a lot of new opportunities and efficiencies to be gained from adopting technology in our services. For example, telehealth and more sophisticated informatics systems so that we use data intelligently to guide business decisions and clinical decision making. Changes of this magnitude have required increased collaboration amongst community partners. That's another positive I think we see. Aware, as I pointed out, Aware is a member of the Behavioral Health Alliance of Montana, BAM. BAM is helping to improve communication between the state and providers and helping to improve advocacy for this system of care. Aware is refocusing on our mission through this time. We're trying to embrace change for the better. Now, having shared experience in going through recent difficult times, for example, many quarantines, they continue to this day. I think we're a stronger team. We're more confident and trusting of one another for what we can accomplish together. What are some of the things Aware is concerned about working in the future? We're all concerned. There's upcoming changes in leadership, Montana legislature and executive branch, and with our federal government, most notably a new president. And changes in administration just simply bring some uncertainty. However, with these changes also brings a new audience. Quite frankly, community-based behavioral health services have taken a beating in the last several years. There have been some massive funding cuts that really were never restored. There might have been some funding that's come back, but it really hasn't met the level of restoration. With ever-changing rules and massive funding cuts. This has not only negatively impacted our businesses and the people we serve, but it in turn has also pressured other systems like law enforcement, hospitals, BHUs, correctional facilities, and institutions like the state hospital. The new administration can bring fresh approaches to these lingering problems. There's some contact information if anybody's looking to contact Aware. I really want to thank Matt Kuntz, Gary Mahelish, Colleen Ron, NAMI for hosting this session. Thank you very much. That's all I got, Matt.
Awesome. Matt, thank you so much for your presentation. Our next presentation by Barb Metler, the Executive Director of the South Central Montana Regional Mental Health Center. Barb has been a fantastic leader in our state for years after I believe we swiped her from Colorado. So thank you so much for joining us, Barb. I can't wait to hear your presentation.
Well, I promise not to be ungodly long, okay? and I can relate to whining. I've been doing a lot of that lately. So just wanted to let folks know that one of the other things is that in 2021, we're actually going to be celebrating our 50th anniversary. And I think that even though we've been around for 50 years, we're the least known program that exists in the city of Billings. It amazes me that we've been here this long and people still go, you were, is that Billings Clinic? With another recent reorganization, we're now down to approximately, I think probably 85 was our last payroll. And the interesting piece of that, though, is that at our ultimate high, we were at 165. But that was in the days when the mental health center still had Bozeman and Livingston as part of this catchment area. But even though we've dropped down to about 85 employees from 140, we've only lost $1 million in revenue. So that kind of tells you how much extra we may have had hanging around. So I think in that sense it was good. But we had to do our most recent reorganization was in October, and I'm hoping for that's going to be the last of it. That I don't know where we can cut anymore. We are so lean now, it's unreal. But yeah, so programs. We have an outpatient program. It's we probably see mental health center approximately 2,000 clients a year. Okay. Our PAC team, program for assertive community treatment. It's of course the program that is hospital out in the community kind of thing. PATH, which is a program for assistance in transitioning from homelessness. It's a federal program. Rainbow House is a drop-in center, well, drop-in program or day treatment program is what they're officially called. And we also have one group home, Park Hill Group Home. We do a significant amount of work with veterans, and we continue to work to expand those services along with the folks at Fort Harrison. Fort Harrison still approves the folks that that they pay the services for. In addition, we have a medical unit that consists of 4 prescribers. We have 2 psychiatrists and 2 nurse practitioners, along with 2 full-time nurses and 1 LPN. So, and I'm sure, as is true for the rest of you, that's a group that's very difficult to find. We could use another one if anyone has one that they just don't need. Over the course of the last couple of years, we've lost 2 programs. Initially, we lost targeted case management. We had a program that had approximately 20 case managers in it and had to close the unit because we weren't able to meet the costs of the program once there were some reductions. Most recently, we had to close our doors on the Hub, and the Hub was our homelessness program for, I think, close to 20 years. And we got into a little fight with the county commissioners, and they basically said either you close the Hub or we'll pull all your money. And they had already pulled 2/3 of it, and we were at the point where we couldn't lose another $170,000. So the Hub has been closed. We also have programs in Red Lodge, and recently we started a clinic in Joliet 1 day a week. We're hoping to be able to go to some of those communities. It's been one of the needs that they've identified when I go to the LAC meetings, is needing services in some of those smaller communities. So we have Red Lodge and Joliet, Roundup, Columbus, Big Timber, and Lewistown. Approximately 2 or 3 years ago, Hardin decided to go and get their services from their local community health center. And so we have not been providing services there since then. Okay. As is the case for most of the folks in the community mental health center, is we've all experienced major revenue losses since about 2017. Rates were reduced, and it wasn't the fault of anyone other than just revenues were not there. But unfortunately had huge impacts on programs that are really important. As we well know, community mental health centers, their bread and butter has always been case management. Not only is it bread and butter, but it's what the community mental health center programs are about. It's what keeps folks out of the hospitals. So we closed a unit that had approximately 20 people. I would say that let's talk challenges. As is the case, I think, for everyone, our biggest challenge has been hiring and retaining qualified staff. We have focused a great deal of time and energy on trying to figure out what it is that we can do. We decided that since it's so difficult to hire, we're going to put our focus on trying to retain the folks that we do have. And so we've done salary increases. We think we're finally getting to the point where we're pretty competitive with our local hospitals and other folks in the community. We are initiating sign-on bonuses. We did the first one about 3 years ago with nurse practitioner that we hired. It's what it took to get them. And when you're looking at quality folks, you got to do what you got to do. And I don't regret it one bit. I think it was a good decision. We're also looking at referral bonuses from our staff. If they know folks who are looking for jobs, then we hire them. We're offering a referral bonus to those folks for their help. Of course, this whole thing with COVID, we did some hazard pay things in order to keep our folks. As you're well aware, our PACT folks were out there still working. They were still doing their jobs, even though the rest of us were behind closed doors. So we did a hazard pay incentive for folks that continue to have face-to-face contact, got about $1,500. And all the other folks that had to keep the mental health center going got approximately $1,000. I do think that right time, right amount made a huge difference for our folks. It really did. We did not lose folks during that period, and we haven't yet. It's kind of interesting. We usually do a like a Christmas bonus or Christmas thank you. Well, this year, $200 of it is going to be more hazard pay for COVID. And then 150 is just our way of thanking our folks for all their hard work and the things that they normally do besides COVID. The area that we really, really need folks is we need licensed therapists. We need licensed ones, but we're also willing to provide, do therapists in training in that our hope would be that we'd be able to retain some of them then. Prescribers, always an issue. Rural offices, incredibly, incredibly difficult to find people to work. I think we were without a clinician on site in Lewistown for almost 2 years. That community happens to have a significant amount of licensed folks for some reason. I don't know why, but we currently have someone there, but we went for like forever using televideo and doing the tele stuff. So what else? I think some of the other challenges that we've seen is we've seen a significant increase in the amount of programs that have been initiated. I was just looking, we have 11 major drug and alcohol programs just in Billings. And that's not private people. That's, like group kinds of programs, 11 of them. We used to compete against Rimrock. Not so much anymore. We got all these other programs going on. Recently added another community mental health center. Alternatives was approved as a mental health center. So programs, what we're seeing is a lot of our folks are going to different programs throughout the community, as in the past where they used to come to us pretty much. So what else? I think actually for me, that's about it. Overview of our programs, where we're going. We do sincerely feel like, in spite of the fact that we've had all these challenges with our finances, that we're in a position to really start regrowing and starting to thrive as far as what it is we're able to provide and what we can do. I will take on anyone when they say that they can provide services for people with severe and persistent mental illness better than the community mental health centers. I don't believe it. They don't have the continuum of care and services that we can provide, nor I think we have, our psychiatrists and prescribers have a specialty in working with the drugs that work for our folks. So I think we will. I think we're going to see that. And just as an aside, I think I have 20 days left till retirement. And so I just want to say thanks for the work and the people I've met through the 8 years. It's been interesting, folks. It's been interesting. So yeah, that's what I have.
Thank you so much, Barb. And I can remember the first time that I met you at a legislative testimony when you were fresh here from Colorado. And I guess thank you for continuing on the great work of your mental health center and setting the stage for what lies to come.
Yeah, I think my only challenge from here on out is cleaning drawers and closets for a while at least. So.
Well, if you can figure that out, please send me your tips.
Will do. Will do.
Awesome. All right. So we will move on to our next speaker. Craig Asved has been leading Shodair Hospital. I would hazard a guess, maybe four years. But the time slips by. I mean, Craig's been an incredibly valuable ally to NAMI Montana and the people that we serve. We just really delighted to have him present for us this morning. Thank you, Greg.
Hey, thanks, Matt. So I was informed yesterday that it was my 5-year anniversary of being at Shodare. So it's been a great 5 years, and I want to thank you, Matt, for giving me the opportunity, and a big thank you to everyone else for who have presented so far. So I'm going to share a screen here. Everybody can see. Can you see my screen? Okay.
Yep.
All right. So what I'm going to do here is I'll just go through and give a history of Shodare. So here, so just listen to previous presentations. Shodare has been around for 125 years. And what this slide will depict is we have been a lot of different things in 125 years. But the one thing that has been consistent is we have always been about Montana's children. So you can see in 1896, we started as an orphanage. We became that true children's pediatric hospital. We were a polio hospital. We became a chemical dependency program in Montana. We became the first genetics program. And then in the 80s, you can see we're really what we are today. And you will see that slide, the last one of 2020, a new project. And I'll talk about that here later in the slide. So let me just talk about Shodare. Shodare is really the only hospital in Montana that provides both acute and residential services under the same roof, which we've been very, very fortunate to have that. The other thing I just want to call out is our mission, which I think is really clear, concise, and it's really who we are and what we do, and that's to heal, help, and inspire help. As I said, 5 years ago, I arrived at Shodare, and one of the things we did back in probably about the first 6 months of my arrival, we really embarked upon becoming a sanctuary facility. And for those of you who do not know much about sanctuary, it's really a model, a trauma-informed model of care that we're really prescribing to and rolling out in everything we do at this organization. And I'm always happy to talk more about that information later. Some highlights on the screen I want to talk about is that we Shodare, and you'll see a map here in a few minutes, we treated kids last year from 44 of the 56 counties in Montana. And most important, 99% of the kids that we take care of are Montana children. And just to break that down for everybody, last year we had 896 inpatient admissions, 253 residential admissions, and we had 4,300 outpatient visits. And then our genetics program, which is a whole nother story here, we had 2,000 laboratory tests last year. And again, there will be talk about a new facility, but I'll talk about that later. So 5 years ago, again, I just want to keep talking about that. If you look at this, trying to create this continuum of care, Shodare really was an inpatient residential facility. And what this slide will show you is that in the last 5 years, we've added day treatment. We've opened 2 group homes on our campus. We're providing school-based services, and then we opened an outpatient clinic here in Helena, and then have thus expanded and opened a clinic in Missoula as well as Butte. And our whole philosophy is really trying to strategically place clinics in areas that are more accessible to larger parts of the state. And then on the genetics, you can see we do everything: medical genetics, cancer genetics, biomedical genetics, and we just recently received a grant in conjunction with the University of Montana for a pharmacogenetics program that we're really, really excited about. So our clinical staff here, and I think this is worth highlighting, on the psychiatry side, we, Dr. Heather Zalewski serves as our medical director, and we have 7 child and adolescent psychiatrists on staff here, 8 nurse practitioners, approximately 41 nurses, and 30 therapists. And on the genetic side, obviously we have 1 board certified medical geneticist physician, 2 genetic counselors, a couple nurse practitioners, and several technologists. And I'm going to talk more about this slide here, about the challenges here in a minute. So let me just keep going here. So if you look at when we tell our story, this is probably the most important slide that we have to tell our story, is that all of these dots represents where our patients are coming from. So you can see from east to west, north to south, that we are serving kids from a large part of Montana. As I referenced before, 44 of the 56 counties were served. And then I would just say you can see 77% of our admissions came from Lewis and Clark County, Missoula County, and so on and so forth, that you can see on the left side of your screen. We also, I want to talk about our foundation, is that its primary goal has been it was founded in 1977. Our primary goal is really to generate resources and support for Chaudere Children's Hospital. Many of you might not know this. We are a member of the Children's Miracle Network, which represents all of the children's hospitals across the country. And what is unique about our involvement in that organization, we are the only children's psychiatric hospital part of that network. So we bring a whole different twist to that entity, and really excited about our future there. Some awards, accreditation Chaudere has received over the years. I've talked about the Miracle Network. We were last year. I think this speaks very well about the staff here at Chaudere, because this is really all about them. We were recognized as the Chamber of Commerce Business of the Year last year. Our Yellowstone, this is our professional liability insurance company. We've received safety awards for 3 years in a row. We're accredited by the Joint Commission, and our school is accredited by the Northwestern Accreditation Commission since 2017. So COVID, and I appreciate all the stories, and I appreciate everybody weathering this storm, because it's like you, this has been very, very difficult. It's had a big impact on Chaudere, like all other organizations. So when this whole started back in March, we made some decisions right away, and those were to close a couple of our units. So we closed our High Desert unit, which is our little kids acute unit, and then we closed a residential unit. And we really thought at that point in time we would have COVID cases, and those units would serve as our quarantine units. So we did that, and then we closed one of our group homes, and really lifted up our outpatient services and started doing that all telemedicine. And after a couple months of that and really no activity, we reopened those units. But you can see the impact from closing those units to us was about $1 million hit. And the biggest part of the story here is obviously you're closing units, you're reducing your revenue, but I was pretty emphatic that we were not going to furlough staff or lay staff off. So I went back to all of our leadership and all of our physicians, and we implemented a 30-day salary cut for those individuals. And it went from up to 50% down to 10%. So some significant reductions, but I just think that really spoke to how dedicated and committed this organization was of keeping our frontline staff. Like many of you, I didn't want to lay staff off to have to go back and try to find them later. So we enacted other things to get us through the hump, and I think we've done that. So today, just so you know, 2 weeks ago, we had to also close some of these same units again, and it was different this time is that we couldn't find staff. We either had staff that were positive, we had staff that were quarantined. So we had closed a couple of units again for a shorter period of time, and today we're back operational at 100%. So the future of Chaudere, what we're really excited about, obviously, in addition to the work that's being done, we are in the process of replacing our existing facility. So construction has started. This slide here just depicts some of the renderings of what this facility looked like. And really what we're trying to do is really build a facility that Montana kids deserve. And it really is a building that really identifies who we are and what we do. And for some of you, just here's some facts. If you've ever been in Helena, our existing facility was a bowling alley and a bar. So we purchased this in 1983 and have retrofitted it to make it work for a long, long time. And it's seen its good days, but now it's time to retire this facility and move on to a new building. So in our new building, there's a couple slides. I'm not going to go through all these. Here's what we're really excited about. We're going to have 82 private rooms. So today, what does that look like? Today, we have 74 beds and 40 rooms. So we are going to all private rooms, and there will be 10 bed pods. So we're really looking at how we can start taking care of kids differently. So we'll be able to segregate kids by their age, by their by gender diversity, and then we will be able to start admitting kids that have more medical needs, as well as more aggressive kids, which right now, a lot of those kids that can't be treated here or in Montana are being sent out of state. So our whole goal is really trying to build a facility that allows kids to stay in Montana. It is our goal and our intent. The new building, again, some highlights. Here's what I'm gonna do. I'm gonna go to this slide here. This is the configuration of what it will look like. So on our first level will be our residential units. And then for our first and second level will be residential. And then on the third level will be acute. And on our third level, we are adding what we call ICU beds. So this is really for those kids who are really challenging, very difficult, that have typically been sent out of state, that will be able to even isolate them further. And what really becomes important in the design of this, so here's been the whole design features of this, is that it's all about safety and flexibility. And we really feel like if we would have had this building a year ago when we had the tragic death on the interstate, we could have prevented that death. So we will, in this new building, like I said, be able to start segregating our kids by their diagnosis, by their age, and by their gender. This slide here is just this is the Shodair campus. We're just shy, of 30 acres. The right-hand side of this screen, you will see is where our new building will go. So what you will see, this orange building is going to be the new Shodair hospital. The blue building is our existing grasslands unit. That will be, in the end of this project, the only building that stays on this campus. So that building, we will house all of our support and administrative functions, but all the clinical services will be in this building. And then our group home will stay here. And then if you can see the left side of the map, lots of room for expansion, and we are part of this project. We are going to build a medical office building that will consist of our genetics program and our outpatient services. And then we're working with other providers to add some other services in that building as well. So we're really going to take genetics and make them their own entity, their own identity, but have them still located on our campus. The project construction schedule, like I've mentioned, we have started when we plan to be in our new building by this time in 2022. So a 2-year project. And once we are there, we'll then renovate our grasslands unit, start demolishing this building, and we'll be full force after that. The question, there's been a press release that has come out previously that we did sell bonds for this project, and we were successful of selling $54 million in bonds, but we're also embarking in a capital campaign as well. I mean, obviously, I don't think this is any surprise to anybody. It's no different than I think many of you, is our biggest challenges going forward are obviously staffing, and that becomes more and more and more of a challenge in all arenas of the mental health arena. And then obviously reimbursement is for all of us to continue to do what we're doing with the same dollars we were paid years ago just is not going to work, or philanthropy is going to be, what separates all of us. And then lastly, just to brag a minute, if you've seen this young woman's face, Bella Nyman, she was a patient here. She was selected as the champion child through our network that we're part of, and she has become a spokesperson for mental health. And if you have not listened to videos or heard this individual speak, quite dynamic, and we're very, very fortunate and blessed that she's the one out, she's the face of mental health for kids in Montana. And then with that, I have, if there's any quick comments or questions, I'd be happy to answer any of those. So again, Matt and everybody, I appreciate the opportunity.
Oh, this is perfect, Craig. Thank you so much for laying out both the challenges that you faced and the excitement of what you're trying to achieve in your next steps. And as a Helenan, I had no idea. As a Helenan who worked at Shodair, I had no idea that that was what happened to Foxfire Lanes. So thank you for solving that mystery too. I'm not sure what part of the bowling alley I worked at, but thank you so much, Craig. We are delighted to have our next speaker from Miles City and the Eastern Montana Community Mental Health Center, Brenda Nealand. Brenda was one of the first speakers that agreed to join when we were trying to decide whether or not to do this. And it really was her email coming back instantly, which was what made the difference in kind of getting over our fear that no one would want to speak or attend. So Brenda, thank you so much. We're delighted to have you today.
Hey, Matt, thank you. And good morning, everyone. Again, my name is Brenda Nealand. I'm the CEO at Eastern Montana Community Mental Health Center. Our agency provides mental health and substance abuse treatment services to residents of 17 counties in Eastern Montana. We have been in existence about 53 years, and we currently employ around 106 employees. We're headquartered in Miles City, and we operate satellite offices in Forsyth, Colstrip, Broadus, Glasgow, Glendive, Sydney, Plentywood, and Wolf Point. Our service region is huge. It's about 48,000 square miles. We provide outpatient mental health services in person and through technology throughout the entire 17 county region. Same with substance abuse treatment. Additionally, to outpatient services, we operate 3 SDMI waiver adult group homes, 2 in Miles City, 1 in Glendive. And we also provide day treatment services in those communities as well. We provide a variety of children's services in Eastern Montana, everything from outpatient care to 12 CSCT programs that we operate throughout the region. Our client makeup, approximately 70% of the individuals we serve are on Montana Medicaid. So that's just kind of an overview, I guess, of who we are and what we do. I followed the kind of the synopsis that Matt had sent. So moving along with that, some changes that Eastern has had and our clients have had since COVID. And I'll start structurally with Eastern. We have worked really hard to keep our doors open through COVID, and we've been, I'm not even going to use the word lucky. I think we're just blessed to have extremely tough staff. They show up every day and deliver the services that we need. We've been flexible in regards to ensuring client and staff safety, meaning if we're able to provide care through telephone or computer, we do so. Some of our offices are located in county buildings. So it's a constant balancing game, I guess, with the 17 different counties. So something might be happening up in Sheridan County and they're going to close the courthouse for a week or two to clean. So that displaces our staff. Staff at that point has been working from home, and we've continued, all of our services. And it's just a kind of a barrage come Monday morning. The calls start coming in. What's happening there? Well, you're closed there, so you're going to be at home. And it's just a constant juggling game. But to staff's credit, they've just been amazing, and our clients have been great. Talk about resilience and adaptability. They're open to utilizing the technology available. And through the state of emergency, for the first time in Eastern Montana, we're able to serve clients in regions where we don't have an office. So we're providing services for the first time to a lot of folks in need. It's not uncommon in our service area for an individual to have to drive a minimum 100 miles round trip to reach one of our offices to attend a CD group or a mental health outpatient. By being able to use telephone and to serve clients in their home, we're able to serve more people. And it's winter in Eastern Montana, and that's not fun either on those 48,000 square miles. So I think all of that is going really well. Yeah, that's been a big change, but it's been one that's been well received by by staff and clients. We were able to keep our CSCT programs up and going despite school closures. We have CSCT therapists driving buses, picking kids up. We rented out churches. We utilize space we have at the agency to make sure that those kids that were receiving services from us continued to receive services. We see them as some individuals very high risk, and this might be the only way we can check on them and make sure they're okay and help them deal with their ongoing mental health issues. So, kudos to our CSCT staff. They've put a lot of miles on buses throughout the region, and it's working. Some of the things that we are currently concerned and both excited about, obviously COVID, we're very concerned about protecting our frontline staff and our group home clients, as well as all staff and clients. But we feel a real deep responsibility to reach out to people in this region who are suffering. They're scared, they're displaced, they might be, jobless, just trying to be a constant presence, but to take care of our own staff as well. We're concerned about, what post-COVID could look like in regards to increased mental health needs, increased substance abuse needs. We're also concerned about people who are receiving our services maybe for the first time, because through this state of emergency, it's opened up avenues for them to have the care they need. And should telephone services be discontinued, or our ability to provide services to clients who are able to remain in their home and have those services, it's working right now. And I guess that's one of the blessings that's come from COVID in Eastern Montana, is that we are able to provide these services. And I worry that down the line, if we're not able to, it cuts off that avenue for a lot of people. So that's on our mind. We are excited for a ton of things. I guess first and foremost, this agency has been approved by the state to provide MAC services in Eastern Montana. Basically a lower level PAC service. It stands for Montana Assertive Community Treatment. These services have never been provided in Eastern Montana before. So we're honored to be the first and to be bringing that level of service to the region, as we work with community partners to address behavioral health crisis and to avert higher levels of care and emergency room entries, ICU beds, state hospitalizations. We're going to begin on also a big thank you to the Montana Healthcare Foundation for helping fund this effort as we start up. We're looking at beginning MAC services in Miles City and serving a 100-mile radius. And once that is up and going, our second goal is to provide services in Region 8, headquartered in Glasgow, Montana. for our northern region across Sheridan County, Wolf Point, dropping as far south as Dawson County. So it's something new, and we're just excited because I think it is something that is desperately needed in this region. We're also excited about the IBH partnerships that Eastern has developed and is currently working on. We currently have clinicians placed in critical access and rural hospitals across Eastern Montana, including Sydney, Culbertson, Forsyth, and Terry. So again, that's a way to have community partnerships, but really present a holistic treatment model to the clients of Eastern Montana. And it's going really well. So we are expanding in several areas of IBH, and that's very exciting. We're also excited for partnerships that we've developed both with Rimrock Foundation in regards to the delivering of peer support services and enhanced chemical dependency treatment services in Eastern Montana, and with Frontier Psychiatry. And I see on the agenda, Eric's going to be up talking later, but that has been a huge blessing in Eastern Montana. For the first time, folks are having access to specialists, the psychiatry level, to psychiatric nurse practitioners in areas that they didn't before. We have basically gotten ourselves out of medication management in hiring our own APRNs and whatnot, and we're working with Frontier. And so we're establishing, they're seeing clients here in Miles City, will be in Glasgow, Sydney, Plentywood, Dawson County. It's just been awesome to collaborate with them to bring that medication management and then have that continuum of care where individuals are referred back for ongoing services through our agency. And I think it's really neat that silos are finally kind of being broken down, and we're sharing resources and working together so that not only our agency, but more importantly, the clients we serve can have better outcomes. So we're really excited about that. I think we're also excited, community mental health, there's definitely a trend, I think, in offering more specialized services. And Eastern is following that path. I mean, we're working hard to differentiate ourselves from other community providers in the sense that we're focusing on our group homes, we're focusing on IBH, we're focusing on MAP services, we're focusing on CSCT, just kind of a specialization that without the communities, it would hurt the communities, and it allows us to kind of go in a different direction than private providers. So we're not all fighting over the same pot of money, and clients are getting kind of lost in the shuffle. When we look forward to things that we're concerned about, or working on the future, I think a lot of our concerns have been shared previously by other speakers. Obviously staffing, it's a constant challenge. It's been ironic in the sense, I think in Eastern Montana, we've always tried to use telehealth as much as possible, just due to the mileage within our region. But COVID's presented a learning opportunity for us, because I think we see staff no longer being so apologetic for presenting quality services via tele. It's effective. Clients are responding to it. But we do worry about ongoing staffing, being able to do that. Money is a constant battle. With COVID, before assistance came out and PPP and stuff, our administrative team here, we all took a 15% cut in pay just to try to keep the frontline staff employed. And luckily there's been a ton of support from both the federal and the state level, and it's allowed us to keep giving the services that we're giving. So we've been really thankful for that. I think, like everybody, there's a lot of unknowns at present, but we're just going to stay focused and keep our eye on the prize, if you will, and that prize being the development, implementation, and maintenance of holistic and effective system of behavioral health care in Eastern Montana. So Matt, thank you for asking me to speak, and I appreciate being here today. Does anyone have any questions, or can I provide clarification?
Yeah, Brenda, that was such an amazing presentation. Like your combination of resilience and just pure grit, and like the ability and willingness to still try new things in the middle of all this is just amazing.
Well, thank you. We got a lot of good staff here. And I think if there's anybody with the resilience, it's definitely our clients out here. So
Yeah,
thank you.
well, your clients and your staff would regularly come to our conference each year, and the amount of road time that they are willing to come for that is truly
They love it.
remarkable. So, and this is replacing that, but for this year, but we're sure hoping to get everybody back on the roads next year when post-vaccine and everything else. So
Exactly. We're looking forward to it.
awesome. Thank you, Brenda.
Yep. Thank you.
And I've got to ask, is Gran on the line yet?
Yeah, I was on trying to figure out this whole mute button.
Oh, okay. So Diani, I'm sorry. We'll let Grant jump in now and give his presentation, and we'll move you back to 12:15.
Great, thank you.
Okay. Thanks for your flexibility. All right. So this is Grant Shinwar from the Billings Clinic. We are incredibly grateful for Gran. I know that there was, tragedy within the Billings Clinic psychiatry department due to COVID, and they're right in the middle of that. But Gran did step up anyway and was willing to present. So thank you so much for joining us, Gran.
Absolutely. And also, Matt, I'm also here with Dr. Amy Schuett. She's one of our medical directors. It always helps to have a clinician here to kind of speak in depth about some of our processes. But, I think what I'm going to share is very similar to probably what everyone else has shared earlier. COVID has had a huge impact on our volumes coming through our psychiatry department in general. What I would also say is that COVID has had a huge impact on our hospital, from causing us to go over capacity on a lot of our ICU units and requiring us to come up with innovative solutions to increase our bed count so we can accommodate those types of patients that are coming in. And right off the bat, we've had to give up a lot of space in our psych center to the main hospital. So that's had some impact in terms of providing therapeutic services to our patients. It's also impacted on, spacing amongst our patients when they're in certain group sessions and so forth. But truthfully, when you're looking at the diagnosis of the types of patients that are coming in, I haven't seen a significant change in the type of patient population that's coming through our department. When we're looking at our youth patients, we have seen an increase in the proportion of, let's say, the adolescents compared to the much younger kids coming through. But, that could naturally be seen as tied to just the COVID pandemic on that patient population, the implications around schooling, anxiety, etc. So we've had to update our processes in terms of trying to alleviate our emergency department. And so there has been somewhat of a silver lining. We've developed some direct admission processes to get our patients quickly over to either our stabilization unit or to our inpatient unit. And Dr. Shu can speak to a little bit of that, of how we've worked with some of our affiliate partners and also some of the other referring facilities to get those patients over quickly.
So, we have tried to expand and do things differently. We are taking direct admits to the adult and child unit since COVID started, if they come from a emergency room or a hospital. And so the process is to not have to go through multiple ERs. And then they can go directly to our inpatient unit without going through our emergency room. And I think the patients have much appreciated this, and it has worked out very well, and it's a better patient-centered care model. We do also still take the transfers directly to our ER that are from outside non-clinic, non-ER hospital settings, and or if we can't get a COVID test or the workup done, then they'll go through our ER and then still through this stabilization unit and then maybe admitted. We have, Billings Clinic has really upped their transfer center, and we have a medical personnel physician on the transfer center during the days too, to help us navigate and be able to do better processing or get patients to where they need to be, particularly here at Billings Clinic. And then, you know, just overall, just expanding, you know, services that Billings Clinic offers to the region with IBH, and we have new telepsych doctors on board, and then we're increasing the number of outpatient doctors, our physicians at BHC, the Behavioral Health Clinic. Unfortunately, we did have some untimely death of one of our partners, and we have a service for him in a few minutes. And he'll be missed throughout the community. That's Dr. Larry Amstutz. He has seen, I think he's been here over 30 years and has seen probably children that he saw. And it is a big loss to the department, but we are recovering and we have new providers coming in. So it's all very exciting. I do want people to reach out if they're having problems accessing inpatient. Reach out to me or send me an email so we can problem solve.
I'd also say that she touched on a little bit about our move towards providing virtual care. So even throughout the hospital, to provide consults, we set up the infrastructure to provide virtual consults. I think a lot of the regulations have kind of been laxed to help us facilitate that type of service. And we further expanded in our BHC to providing telepsychiatry, not only for our provider staff, but also to help our patients get enhanced access for care. And I think over the course of this pandemic, some more additional silver lining is that we've been able to provide a service that has decreased our no-show rates. So we're actually having increased attendance of some of these follow-up appointments, which is great. In addition to that, Dr. Schuett mentioned that we're providing telepsychiatry to the region. We've employed some telepsychiatrists. We're actually looking to employ additional telepsychiatrists. With all our fingers crossed, that CMS kind of helps formalize or makes these rollback on the telemedicine regulations a permanent stance going forward. I think this pandemic has kind of brought to light the fact that telepsychiatry can be just as beneficial as in-person psychiatry. I think in a nutshell that covers a number of different items that we've done here at the clinic, but it's a day-by-day situation. Every day we adjust our care, we adjust our processes, we deal with shortages in staffing. And yeah, I don't know if you have any questions.
Thank you so much for your presentation, Grant and Amy, and we're really sorry about Dr. Amstead. He was just such a light every time I interacted with him. He'll be dearly missed. I guess I would love to get a little bit of a update on your psychiatric residency program. If you're able to do that, I know Dr.
Oh,
Kelso's
sure.
not on the call.
Yeah.
So we already have residents and they're in University of Washington. Our second groups just started in July. So they do the first 2 years out in Seattle, and then they'll do their third and fourth year. And the idea is to train people who can be leaders in the region for outreach and lead teams. So that's kind of the mission of the residency. And so our residents, their third year residents will start this July, and they'll do various rotations. Most of it's going to be outpatient and regions, and being a part of the IBH. The other big part is using ECHO format to get cases in and discuss cases, and then do a learning module along with that. And I hope people are able to participate that across Montana. And then also they'll be working on consult liaison and then other various rotations. So we're very excited to have 3 of them start in July, and then we are interviewing for our third group this fall.
That's wonderful. So they'll actually be on the ground this summer, or cool.
Yes, this summer.
Well, congratulations to your team. I know that we advocated alongside the Billings Clinic, boy, since like 2012 for a psychiatric residency program, and for you and your group to lead it forward. We're really grateful to have that, because I think everybody has mentioned before about the challenges of the workforce. So kudos to the Billings Clinic for stepping up and getting something done about bringing more psychiatrists to Montana.
Thank you,
right.
Matt.
Excellent. Thank you. So we will now begin our transition over to Sydney Blair. Sydney Blair is the executive. Oh, and she wins for the best background. So far. So Great Falls is beautiful this time of year. So Sydney Blair is the executive director of the Center for Mental Health in Great Falls. She's been just a long time devoted leader in providing mental health services to people in her catchment area and to people beyond. So Sydney, we're so grateful to have you here today. Thank you.
Thank you, Matt. That was really a nice introduction. Yeah, I have been at this for a while, but it's really the mission that gets me out of bed every day. And I'm, really overall really excited. I'm sure that other people have mentioned that COVID really came at a time where I think a lot of change was happening anyway in behavioral health, but I think it just kind of allowed us to challenge some of what we thought we were doing well, or what how we could deliver services in a different kind of way. So I think a lot of really good things have kind of come out of service delivery as a result of that. But before I go too far ahead of myself, let me tell you a little bit about our organization. Center for Mental Health has operated for 46 years now. We are a regional mental health center, which means we have offices in Cut Bank, Havre, Conrad, Choteau, Great Falls, Helena, Whitehall, and Townsend. We have a large continuum of services. I think that's what really makes us different from other people and other providers. We have a pharmacy, we have a dental hygienist. We're in the process of moving in or implementing primary health in the building for integrated health services and care coordination. We've been working on that project for a while, and COVID kind of interrupted it. So we hope to have that going by the first of the year. Other programs that we have are supported employment, housing, residential care. We have both foster care, group homes. We have outpatient therapy and medication management for adults and children. We just kind of expanded into children for medication management. We have school programs. We have contracts. We used to have contracts serving veterans. We still serve veterans. We have case management and other daily living support kinds of programs and day treatment. So the things that our organization has done during COVID have really been to try to continue to deliver service however, whenever, and expand at the same time, anticipating that the need is really going to go up. And that's what we're seeing nationally, that there's those estimations of anxiety disorders going up threefold. So we really wanted to be able to move into that, those telehealth kind of platforms. And of course, DPHS and AMDD worked really hard at getting those waivers in place very, very quickly. So our staff were able to do both either phone calls or do telehealth kinds of Zoom kinds of services in that way. You know, we did a survey through BAM and it was, I think other programs had really been relying on it to a larger extent. We're about 20%. So we really kind of felt like it was important that we needed staff in the building to support each other, as well as the clients that came in. And I think it also reflects that we have a lot of other types of services that cannot be done telehealth wide. But like Brenda kind of mentioned, we CSCT programs have kind of, we've really had to pivot a lot in those areas. So we are using our basement in our large, it's actually, our building is in an old school. And so down in the basement, which is a daylight basement, we have alternative kinds of learning environments for our kids where the schools are either closed or they can't. That's not a good environment for them, or their parents don't want them to go. So that's what we've kind of done with that. And we, besides telehealth, we have had to modify day treatment services to offer multiple, like 2-hour shifts, I think it is, or 3-hour shifts throughout the day. So we've had to kind of move our staff around a little bit so that we can serve folks that really depend on it. More recently, because of the numbers going up in our counties, we've shifted to, we're not open to those that live independently. What we found, it was just really tough to manage because somebody would be COVID positive and so they'd be at home, but their partner in the house would come in. They really didn't understand that that wasn't a good idea. And so just to make sure that we're making sure that our clients are safe and our employees are safe, we just said, well, okay, we're gonna close for now, which is kind of, you know, whenever possible, we would rather not do that because sometimes people go home and never come back. And of course, that's the concern. And I think during this time, what we've seen is sometimes clients isolate. And again, we're concerned about those folks. So in some cases, when they did kind of drop off, we've kind of ran those histories and then called them up and tried to re-engage them to make sure that they're being taken care of and that they're okay in the end. What is our organization concerned about and excited about? We are really hoping that Montana decides to continue to have telehealth as a platform that's that we're able to get the same billing for as we would if we were in person. And I think, of course, it's great that there's that renewed commitment to Medicaid expansion. I think that I would really support that and would hate to see that reversed at this time, especially concerning those that are likely to be unemployed or lose their insurance because of reduced hours. I think that telehealth platforms really allow us to reach other populations that wouldn't otherwise be willing to come in, especially in our rural offices where we do serve, and for the younger, for some people who are used to those platforms or prefer those platforms. So I think it's just a way of reaching a lot more people and increasing ultimately access to services. So, you know, I'm a huge proponent of, I hope that we can continue with that. What are we excited about? We're excited about expanding, as Brenda talked about, into our rural region. We're looking at a MACT program, a Montana sort of community treatment team up north. So it would be Havre, Chinook, over to Browning, Cutbank, Shelby, that northern area. So we're excited about being able to deliver services to that level of services to people who wouldn't have had it otherwise. Our commissioners are very excited as well. We're excited about the telehealth platforms and expansion in that area as an agency. We have a new website that we expanded, and we're really kind of marketing in a different way so that we can get the word out so that people can have access to services. And I'm really excited about the Montana COVID stress line that was put in place by DPHS and the governor's office. I think that what that really ultimately does is kind of legitimize the, you know, this pandemic is going to really affect a lot of people in a way, in their behavioral health, in their mental health, in their well-being. And so it makes it okay to get help. I think it's less stigmatizing. So I think it's a really great, you know, first step. What are some of the things that our organization is concerned about for our future? Definitely recruitment and retention. Right now, we're looking at adding 40 positions with the expansion of our PAC teams, our sort of community treatment teams. And so we have difficulty sometimes competing in wages because other providers are, you know, set up differently in terms of quality rather than quantity. The other challenge with retention of staff is really asking them to get comfortable with the unknown during this pandemic, never knowing when it's going to end. And that kind of that moral injury of asking people to work because they love the mission and they love coming to work, but at the same time, they're putting maybe themselves or their loved ones at risk as they come to work to serve. That makes it tough to retain. During this time or early on, we saw a whole lot of shifts happening in our staff. Some of them moved out of state, and again, thank God for telehealth services. We were able to hang on to them and have that continuity in people's care by saying, "Hey, do you want to stay on board with us, and you can do it through telehealth." So we were able to work out a couple of situations to keep that staff and that workforce that really is needed, and and I think one challenge for us as and for other providers as well that have multiple agencies in multiple areas, it's really not, you know, you're not managing services out of one building. It's managing many buildings, many staff with many new managers sometimes who need a lot of support. And it's staff that really need connection more than ever. So what we're doing is we have some committees that are basically talking about how do we maintain that, you know, give additional support? How do we communicate in a different way? How do we, you know, connect and I mean really connect and show that compassion and support for our staff so that we can retain them. Another thing that we're concerned about in the future is really fee for service. We just really look forward to providing quality rather than quantity. I think fee for service kind of encourages that. And so I would like to see us move into those arenas of where we're getting paid for performance and quality rather than for just widgets and quality for quantity, basically. And then I think issues ahead. I think I've already stated that. Really, it's finding sustainable funding streams, and it's really about making sure that you have those services that that people they know how to access it when they want to access it. And it's really about anticipating what they're going to need before they even know it. I think that's our future. So that's all I have. Thanks, Matt, for the great introduction and for asking us to be a part of this.
Thank you so much, Sydney. What a great example of you and your staff and what you've worked to overcome while still expanding at the same time. Now I'm delighted to introduce again my friend Deani Bingham. Deani is a longtime leader in peer support in Montana. I remember walking with her at the peer support rally, but before we were able to get certification and billing and everything, and I believe that she was one of the first people saying what could peer support do for our Native communities in Montana. So we're so grateful for Deani's vision and all that she does, and for the Rocky Mountain Tribal Leaders Council for just being such a great voice for their communities across the state. Deani Bingham.
Thank you, Matt. That was a great introduction. Thank you so much. I'm just going to pull up my presentation really quick. Okay, so good afternoon, everyone. My name is Deani Bingham, and I'm the project manager for Tribal Epidemiology Center Public Health Infrastructure grant from the CDC at the Rocky Mountain Tribal Leaders Council. And I actually work at the Tribal Epidemiology Center. So my role has changed a little bit since my work with peer recovery support, but I still am very much committed to that and to the all of the work that we did. Just a little bit about myself too. I am a member of the Assiniboine tribe from Fort Belknap, Montana, and I'm also Blackfeet and Little Shell, but I grew up in Helena, Montana with Matt and spent my weekends in Butte with my grandparents. So a little bit about the Rocky Mountain Tribal Leaders Council is we are an intertribal organization. And so our vision is healthy, prosperous, strong tribal communities for our tribal people living in Montana, Wyoming, and the Shoshone, Bannock, and Idaho. So we are the Rocky Mountain region, which is Region 8. And our focus is serving tribal governments and their systems and leadership with informed decision-making support through epidemiological research to really support health policies. And we also promote healthy tribal communities, families, and children through our programming, which I'll get a little bit more into later. And we're an advocacy group. So we have our tribal leadership on the board of directors, chairmen, and tribal members serve on that committee. And then they work together to advocate for issues that impact us as tribes collectively, but also individually. And we do all of our work through grants and tribal subawards. So a large portion of our funding actually goes right back to the tribes. And we also do coalition building, policy and advocacy, and public relations and partnerships. And you can find out more about the services at our website. So a little bit about who we are, the tribes that we serve. I always like to just share all of the tribes in Montana. We are a very rich state in terms of tribal nations and history. And so we actually serve the Blackfeet, Crow, Northern Cheyenne, Chippewa, Cree of Rocky Boy, Confederated Salish and Kootenai, the Little Shell Tribe of Montana, which an amazing news, actually a year ago today, or not today, but this month, they were federally recognized after a long journey, really pushing to become a federally recognized tribe. They were always a state recognized tribe, but now they're federally recognized. So there's a lot of work that is being done right now with Little Shell to help them get their health systems in place as a newly federally recognized tribe. Also, the Assiniboine and Gros Ventre tribes of Fort Belknap and the Assiniboine and Sioux of Fort Peck. We also work with the Eastern Shoshone and Northern Arapaho at Wind River and the urban centers, and we have affiliates in Idaho. I just like to share a little bit about Montana when I do my presentations. This is actually outdated information, but there are close to at least 78,000 American Indian members or people with American Indian heritage in our state. And that's actually a low count. That's from the 2010 census. So that number has grown, and I think it was undercounted anyways. And we actually have 12 tribal nations living on 7 reservations and in 1 urban area, which would be Great Falls for the Little Shell. And I just like to share that we do have great tribal colleges. There's actually tribal colleges on each one of the reservations, and you can find out more with the American Indian Higher Education website there. And we're very lucky to have Indian education for all. So Montana is like the first state in the union that made it a law for all of the people to have education about the tribes and the tribal nations that call Montana home. And we're also very lucky to have the Traditional Native Game Society, and then also the Native American Made in Montana. And I really like to talk about that, the importance of Native American art and supporting Native American artists, because not only is art healing, but supporting the artists is supporting the local economies, which we know actually improves mental health and the overall wellness of the community. A little bit about Wind River as well. We do serve Wind River. So there's actually 2 tribes that are on the Wind River Reservation, the Eastern Shoshone and the Northern Arapaho. A little interesting fact about that is that the Northern Arapaho were located there after the Battle of the Little Bighorn, which was 144 years ago. And it was meant to be temporary, but they are still there today. And so the 2 tribes call that reservation home. And then also Wind River is the home of Sacagawea, so the Shoshone woman who led the Lewis and Clark expedition. So a little bit about what has changed since COVID. We have been working just pretty much primarily on COVID for the past 7 months. We have received millions of dollars in funding from the CARES Act for COVID-19 prevention and public health capacity building. Like I said before, a lot of these are being subawarded out to the tribe. So we're providing technical assistance on these subawards and providing ongoing trainings and monthly update meetings with the tribes. We're working remotely. Some of the staff is in the office. I am at home. So we do have staff all over the place. We have a ton of Zoom meetings, just like everybody else. It's just been crazy with the Zoom, but we do meet monthly with each tribe. And we have a surge staff that was provided to us in collaboration with the CDC Foundation. And so we have 2 additional epidemiologists, 1 additional communication specialist, and 1 training coordinator, specifically for COVID-19 related activities. And they're actually located all over the country. So like our training coordinator, she is in Lander, Wyoming. Our communication specialist is in New York. And then our epidemiologists are all over, and one of them's in Nevada, and one of them's in Anaconda. So our tribal pandemic response efforts, we actually started off with the assessment that we did with the tribes to really look at what was going on with the pandemic and their responses and see how we can better support them. And so partly what we found is that most of the tribes are offering financial assistance to their tribal members during this time. There's been a lot of losses in jobs. There's been a lot of layoffs and people working from home. So a lot of the normal financial situations, of course, are very, very impacted. And so the tribes have been offering assistance to the tribal members in the form of about $500 to $800 on average. And that's usually a 1 or 2 time situation. There's also a lot of curfew restrictions and stay-at-home orders. So there's been basically almost complete lockdowns in every reservation, which has severely impacted the ability to provide services for like substance use disorders and mental health. And so it's been very difficult, I feel, for the people to get access to care at this time. And there's also incident command teams that are in place that are really working on getting those contact tracing and all of the COVID-19 response in place within the community through partnerships, education awareness, and then right now we're working on vaccination preparedness. We also have a little card. It's a helpline for people that they can talk to someone if they are in distress. And so that's something that we do share with the tribes. And I'm looking to get more data on that to see how it's going and how people are being helped by that and more specifically. And then we're also working really like looking at those Indigenous public health communications. So we're really trying to indigenize all that we do. And so we looked at some of the work that the Native American language program did. And so they're using tribal languages to promote public health behaviors. And we want to continue to do that. And I feel like that's actually a very good model for mental health as well, is to really use our languages, because not only is it more meaningful culturally, it gets people's attention in a different way within the community. So we are excited about a lot of different things. We're working with our epidemiologists on COVID-19 surveillance, our data dashboards, and our weekly reports to the tribes, and then also aggregate. We have collaborated with the CDC Foundation to distribute thousands of PPE to the tribes. And so that's been something that has been well received. And we also reach out to the urban Indian centers, which you see that there is an urban Indian center in pretty much every major town in Montana. And then we're also excited about just more funding that we are receiving from the different grants, especially from the CDC, to provide subawards and technical assistance for these public health collaborations. We've also been really working a lot on doing our virtual training. So you can see that we really are focusing on like data management. And I think for us, we're really looking at how to really help the tribes make those informed decision makings through data expansion. And we're also looking at those tribal public health communications and the cultural competency. That's something that we've really focused on over the past couple months. And I've developed some presentations specifically around cultural competency to really ground our staff so that they can provide the best, most culturally relevant support possible to the tribes that we serve. We also have health education and training materials at that link right there. And we did do a prevention and awareness video. We did have quite a bit of ourselves in our own office. We did lose a colleague to COVID-19, and every staff member has been impacted by COVID-19. And so it has been a very trying time, just dealing with the loss and not being able to really say goodbye to them. Also, concerns and challenges. One of the things that really concerns me is that Montana actually ranks 3rd in the nation for the disproportionality of American Indian, Alaska Native COVID-19 deaths compared to our population. We actually are in the top 3 with Alaska and New Mexico. And so this is just something that I feel like is that needs to be brought up. I did bring it up with our leadership, so they are aware of it. And then also we're working with some of the other epidemiology centers to see how we can work together to really look at the disproportionality of this. It's very startling actually to see that we are in the top 3 in terms of morbidity and mortality for our tribal communities. And so this is causing a lot of stress on families and children. I know for my family, my husband, we have some young family members who lost their grandma to COVID-19. And I know that they're still very much dealing with the mental health impacts of that loss. And then just on top of that, so many other losses within the community. And so I wanted to share with everyone that this really great resource, it's called Native Youth Are Medicine. And it's actually a State of the Native Youth Report for 2020. And also that mental health impacts, just the isolation, the financial stress. And so we really are aware of this and doing all that we can to support tribes to reach out to their people with messages of support and hope. And we're also really working a lot on the vaccination distribution, education, and awareness. And if you are all interested, there's the IHS vaccination plan right there. So we're all actually working on a health subcommittee. And so that would be an opportunity. Dorothy Dupree, who's the former Indian Health Service director, she came on board as a contractor and she'll be leading those efforts. And so that'll be an opportunity for us to be more engaged with you all and have a forum for you to provide updates to the tribal leaders and the health directors. And we also got some grants and some funding for adverse childhood experiences and domestic violence prevention, as well as a new TOR grant cycle. We are looking for a TOR manager. And we also provide suicide prevention and domestic violence prevention evaluation support to the tribes. And so that's something that we work on as well. And we are also working on behavioral health reports and some opioid related reports specifically that are both aggregate and tribally specific. So that is really quickly our update. We are doing a lot, but that's my contact information. And just please reach out to me if you have any questions or if you want me to do any other presentations. I'd be more than happy to do that. Thank you so much, Matt, for the opportunity.
Thank you so much, Deani. It's always amazing to see what you and the Tribal Leaders Council are doing, especially during COVID. I mean, there are groups that have just stepped up amazingly well, and you guys are flat in the middle of that. So great.
Thank you.
Great work. So I am delighted to introduce our next guest. And I think it says something about the times that we are in and how they have changed, that the next guest of the mental health sensing session lives in Seattle, and he's with Montana, Frontier Psychiatry, Dr. Risa Hosseini Gomi, and just an amazing guy. We have worked together and talked for, I guess, pretty much since Dr. Eric Arzubi and him began to found this Frontier Psychiatry and expand their care throughout Montana. I do want to say one shout out for Eric at our last sensing session that we had in like 2017. Dr. Eric Arzubi said, telehealth is coming and it is going to change access. It's not going to change everything, but he flat out said it's coming and it will change how we do business. And I think that there's no doubt that that has proved to be correct. So Dr. Risa Hosseini Gomi from Frontier Psychiatry. Thank you.
Hey everyone, you hear me okay? I'm going to share my screen here. Okay, cool. You see that okay, Matt? Okay, awesome. Thank you all for tuning in, and it's actually great to. I look forward to reviewing this resource afterwards too. It's great getting a sense of what's going on across Montana. As Matt mentioned, I'm based out of Seattle. I come to Montana fairly frequently. Pre-COVID, it was every month, and I'm hoping to return to that pretty soon. Of course, travel's been challenging. I work directly with Dr. Arzubi and then Dr. Seiss. I'm just going to give you guys a little presentation about the company we started, what we're trying to do, and how it's different from traditional care delivery methods. So I'm just going to jump right in. So we were founded officially last year. We started this company in Montana. It was the three of us, and we had no idea COVID was coming. We started it actually, just a few months before COVID even kind of came on the radar. And of course, in a lot of ways, COVID sped things up. And so fast forward, now we have 6 psychiatrists and 4 advanced practice nurses and nurse practitioners. So we're growing quickly. We're still recruiting, but our whole goal was to really try to bring psychiatric care, high quality psychiatric care across Montana. And we kicked off with our very first patient being served in March of this year at the Montana Mental Health State Nursing Care Center. And so in terms of what drives us, we wanted to address a few things. We wanted to accelerate access to psychiatric care. We were responding to the fact that wait times can be long. Distances were also at times are very often very far. And so we wanted to really close that gap. We wanted to make it as easy as possible to deliver care. So delivering care in clinics, in hospitals, emergency rooms, in the patient's home. We really dedicated to building all virtual team, although I won't be surprised if in the near future we'll have some brick and mortar type of stuff going on too, but really the focus is virtual. We want to bring the highest quality care. So we really are recruiting subspecialty trained mental health providers to bring the same access to care as if you lived in anywhere else, even if you lived in a major city. We didn't want it to be any different from Montanans. And we want to really make it accessible. Few words just about the founding partners, Dr. Arzubi. So Eric is, he wishes he could be here. He's just taking a different, another call right now, but he's really the visionary behind this. He's been in Montana for a number of years. He's really gotten to know the environment and the stakeholders, and he's just been a wonderful ally and friend and introducing all of us to everyone that he knows in Montana, sharing his network. And he was previously chair of psychiatry at the Billings Clinic, and now he's doing this full time. A little bit about myself. I am an engineer turned neuropsychiatrist. So I did training in psychiatry, but then I went on to do training in movement disorders under neurology and also behavioral neurology. So really focusing on neurodegenerative brain disease. As far as I know, I'm the only neuropsychiatrist practicing in Montana. You know, I read all my own brain imaging. I do all my own subspecialty testing to really nail down rare neurodegenerative disorders, the complex interplays we always see with dementias or different Parkinson's, things like that, with behavioral issues and psychiatric issues. So that's really the population I see that I'm heavily focused on. And then Dr. Seiss, who will be joining us full-time clinically very soon. He also is one of our co-founders and has been at the Billings Clinic the last year or two. And he has a big specialty in addictions. He's one of the leading addictions providers in the state as well. He was trained in fellowship at the University of Washington and the the Puget Sound VA system. In terms of services, we want to really, again, provide direct patient services. So we want patients to see us for their psychiatric needs. We also want to adopt collaborative care models or other models that will help spread psychiatric services to the community. So we don't necessarily need to do all one-on-one care, but can we help primary care clinics, critical access hospitals review their patient databases and identify at risk and do some proactive looking. We want to also train and be part of supervision for future psychiatrists and also our advanced practice nurses who are extremely helpful and are vital to our success. We do weekly rounds. We have case conferences every week. We do didactics every week. We're really trying to maintain the highest level of education training and make sure everything we're doing is up to date. This is just a little quick snapshot of our current locations with a number that will be added soon by the end of this year and also in 2021. Excuse me. We quickly started providing health care to the Eastern Montana Community Mental Health Centers. So a big shout out to them. They jumped in, took a chance with us, and we've had several of their locations go live, and that's been wonderful. Our average wait time to get in has been less than a week, and we've been able to maintain that across the state as we've expanded, and in some cases within a day or two. So we really want to stick to that. We're working hard to not let that get any longer. Also, big shout out to Alpha House and Passages, which are wonderful programs. I mean, truly impressive models for the entire country with helping people who have spent time in prison transition back to the real world. So they can help them get jobs, they get their mental health in order, social supports, staying clean. I've been seeing patients there now since we started with them, and I've been very impressed with the services they provide. And you can see just across the bottom, and I will call out all of these partners in a little bit. In terms of COVID-19 impact, I know that's kind of the main focus of today. You know, in some ways it accelerated growth for us. Of course, the openness to telepsychiatry from patients who may have been kind of on the edge about it. You know, there's privacy concerns. It's a lot of unknown. It's a new technology using a video chat. There's also concerns about the quality, being able to match that. And then providers also being more open to using it to provide care. So that, of course, accelerated it for nothing else than being necessary. I mean, we had a lot of limited in-person resources. The couple of things that have really come up that have challenged us are in-person, so the delays for insurance coverage. Of course, COVID's delayed everyone, so this is not a knock to the insurance industry. It's just the reality of COVID that everyone's dealing with, but very, very long delays. So we've had It's taken us a long time to get credentialed for many of our organizations. Keep in mind, one of our main goals is to provide psychiatric care to those most in need. So we started at the Medicaid, Medicare level, and those are our main group of cohort of patients we cover are at that level. And then we've been adding on other insurance plan, private insurance. We finally have Tri-West, so we can take care of veterans, which was one of the things we've been pushing for a long time. They had significant delays in processing, but finally that's gone through. And a big shout out to Senator Tester's office for helping us make those arrangements. And so that's been one issue. Also, it's an interesting balance in Montana. Montana was one of the first states in the country to bring parity to online telehealth being reimbursed the same as in person. So Montana's led the way in a lot of ways. Now, one of our concerns is with private insurers, others, not to roll back any of the COVID era restrictions that they kind of loosened up. So we don't want to go back to a time where they might force patients to see certain providers or have more restrictions. So we're working with them. I think we can all work together and really help keep an open climate for care. A big shout out to Blue Cross Blue Shield Montana. They've been a huge supporter of this, and so they are not. They're doing what they can to not follow some of the other national trends from other states, and they're keeping their insurance open to patients across Montana to keep seeing us even after COVID. We have to really give a big shout out to the state of Montana, the governor's office, Governor Bullock, AMDD. It's been a wonderful collaboration with Lewistown, the nursing care center. Those are things that really got us off the ground and gave us enough momentum to survive COVID. Also, the business stabilization grant, the business adaptability grant, huge supports. The Montana Mental Health Trust has come through for us and provided funding to set up emergency psychiatric services, which I'll mention a little bit later. And then the Montana Health Network, those critical care access hospitals I mentioned on that map earlier, for really taking a chance with us. So really, people have really come together and given us a lot of support, which we really can't thank enough. Just a little bit to kind of wrap up our vision. We want to build this all virtual team of psychiatrists. We see ourselves providing 3 different levels of acuity care. So we have our lowest level, which is primary care, integrated behavioral health, being co-located, and we've started doing that. We're in a number of centers already. Medium acuity is what we're now working on, as well as a high acuity. So specialty care, drop-in clinics, urgent care. So people that want to really be seen the same day. And then high acuity, which we have now funding from the Montana Mental Health Trust and support with several partners to roll out. And emergency rooms, inpatient psychiatry, empath units, crisis care, things like that. We want to make sure that if you're in Montana, you don't have to go anywhere else to get the mental health care that you need. So we have adult adolescent psychiatrists, we have adult general, we have geriatric psychiatrists, forensic, addiction, neuropsychiatry, perinatal. We have subspecialty trained psychiatrists really across the whole spectrum. And as far as we know, we're the only clinic or really partnership in Montana that offers all specialties. And that's something we're really proud of, and we're continuing to recruit. A couple of just notes about what's coming soon. So more about the urgent care emergency care service line. So I got to give a big shout out to Shodair Hospital. And I think Craig is on the call, but wonderful support from them. They've been a huge partner and taught us a lot about the dynamic in Montana, the environment, and really supported this work. And then the Montana Mental Health Trust coming through with this grant. So we're excited. We're going to be rolling out a model where we're going to have, basically iPads just deployed to emergency rooms. We have a software that we built within Montana that will take in consults, and we'll have response times on the order of one hour or 4 hours, depending on what they need. We're going to be turning around care quickly and just provide support in places where otherwise patients were sometimes waiting for days or being shipped for hours, to other places. And so that's one thing. And then another thing is the perinatal consultation line. The state and federal funded consultation line will be open to all Montana providers caring for pregnant and postpartum women, where we're staffing this with trained perinatal psychiatrists to offer the highest level of care. We'll be launching that January 1st. And by the next year, it's going to be starting with a few locations, then ramping up in a few different levels, and then we'll open up to the entire state. Hopefully all goes well. And then just our last slide, just a few mentions for media coverage that we've had to check out some of these links. And this is where I can make my shout out to Charlie Health too, who I know also presented on this call, who's been a wonderful ally and partner in helping reach children. So that's a bit about us. And if I did not mean to leave anyone out unintentionally, the main kind of point to take away is that we've had incredible support. So COVID for us has been really dampened quite a bit, the challenges by everyone coming together and helping. So thank you, everyone.
Awesome. Risa, thank you so much for your presentation. We're just delighted to have your work in the state and can't wait to see as you guys continue to roll out. And Risa's introduction to Charlie Health could not have been much better. So we didn't prep him with that, but next up we've got Laura Sobolski of Charlie Health. Charlie Health came on hard on the scene in the past year, and I just am delighted that anybody gives me the opportunity to put an entry in every county of the Montana county resource guide that we have. So Laura, thank you so much for being here today.
Thank you. I'm going to share my screen as well. Can you see my screen okay? Cool. Okay. Are you just seeing the presentation as well, Matt? Okay, cool. Well, I just want to thank you, Matt, for always including Charlie Health and everything. You've been a wonderful ally, partner, and confidant to me specifically, since we're the new kids on the block. And there's a lot of things to try to understand here in the state of Montana, a lot of difficulties, and COVID has just really just exemplified a lot of them. But thank you so much for inviting me to speak with all of you and talk about Charlie Health. Like everybody else on this call, I'm incredibly passionate about mental health treatment, particularly for adolescents and young adults in rural parts of the country, specifically to Montana. And Charlie Health, you know, we're a new company founded on passion and purpose. And our purpose here is mental health resources and access for all. And Montana couldn't need it more. So a little bit of history about us. One of our co-founders, Justin Weiss, he suffered a traumatic brain injury when he was in college. And from there, it just spiraled into major depressive disorder, anxiety, isolation. And out of loneliness, he was trying to seek a community where he could, you know, try to undo some of that and heal himself. And ended up going to VA meetings because that was all he had access to. So, you know, it just really didn't make sense for what he was going through. Simultaneously, his best friend, Charlie, was in a very rural part of upstate New York and started experimenting with substance use, turned into depression, turned into anxiety, and tragically he lost his battle, and he didn't have access to care. So that's where Charlie Health's name came from. Our co-founder's best friend, his name was Charlie. So we wanted to make a change. You know, mental health has affected all of us personally. I'm sure it's affected a lot of you personally on the call too. So this is truly like a mission based on passion. And after 2 years of research and outcomes, our team finally decided that Montana had the greatest need. And a virtual IOP for adolescents and adults is how we decided we can support all the clinicians, hospitals, individual therapists, school counselors around the state. You know, it's a new type of service in Montana that is here to fill a void. And we need all the providers to be successful to revolutionize mental health care in Montana. And that's really where Charlie Health steps in. Next slide. So just to talk a little bit more about our services, some examples include group therapy, which is really what an IOP is, intensive outpatient programming. It's truly an insurance term. It's 9 hours of group therapy per week. It's after school, it's after work. Since we're completely virtual, we're able to treat clients whenever is good for their schedule. So we have many groups running at all times of the day. And in those groups, it's DBT skills, process, trauma, acceptance and commitment, CBT groups, emotional awareness. And the goals here are our therapists are using all of these different types of groups to build connections between peers, to show support, to role model healthy communication, and to really heal all together. And I think it's important to note that, you know, we want people from all over the state to be able to connect with one another. And because of the rural aspects, we just haven't been able to do that. Sorry, I need to move my screen a little bit. So one thing I want to talk about, because this is virtual and Charlie Health has always been virtual, and this is from pre-COVID. Our journey has always been telehealth, and COVID just expedited that for us. And really, our no-show rates have been the lowest that we've experienced, with only 4% of patients no-showing since we began treating clients over the summer, which is extremely low. And we repeatedly hear from clients for the first time in their life that they're feeling supported through our group therapy modality. And they're feeling supported by people who understand them. As I just mentioned, the core of Charlie Health is group therapy, because we believe in the power of connection. And right now, COVID is not allowing us to have the connection that we're all very used to. It's just not the same. So we want to connect kids in Eastern Montana struggling with gender to those in Billings who may have transitioned. We want to have curated groups for girls with sexual trauma who may have attempted suicide, to know that they're not alone and that suicide isn't the answer. And then for the 17-year-old boys living on, reservations with 6 siblings in a house, they're abusing alcohol, they have nowhere to go, they can't see the light at the end of the tunnel. We want to introduce them to peers that have made it through to the other side and give them hope. And that's really what Charlie Health is doing. Slide. Sorry about that. So we're serving right now 12 to 27-year-olds. We're working through a HIPAA compliant platform called Aliva. It's our EMR. And all of our treatment sessions are conducted live with our master level clinicians. We're constantly recruiting, because another part of our mission is we don't want to have a wait list. We want these kids and young adults, teens, young adults, to have access to care immediately as soon as they need it. So we're able to start the process and get them enrolled within 24 to 48 hours with our master level clinicians. But before we move on, I really want to just touch on what's happening in Montana. And this is thanks to NAMI. This is something that we use a lot because it's important to understand how complex the state of Montana is and everything that's going on, and why telehealth is so important. Just some quick facts. Social isolation, Montana has 6.7 people per square mile. The national average is almost 89 people. Pair that with mandatory quarantine and isolation, not going to school, not being able to see your coworkers. It's not good for your mental health. Socioeconomic status, 1 out of 5 Montana kids live more than 100% below the poverty line. Charlie Health, again, access for all. We're a network with Medicaid. We have a sliding scale. We are able to have scholarship funds. We will walk clients through the application to the Medicaid insurance through that process if they're unable to do it, or maybe they don't have the parental units to help assist them. Like, our team is willing to go through that process with them. Using alcohol as a coping strategy. We know that substance abuse, you know, the primary thing is mental health. If you're using substance abuse, something else is going on inside. We want to be able to help and work with substance abuse professionals on getting that client's mental health where it needs to be. Access to lethal means 65% of suicides are from a firearm, and nearly 90% of firearm deaths in Montana are suicides. It's really alarming. The stigma, I know a few other people have talked about the stigma. Montanans see depression as a weakness. We live in a very agriculturally heavy rural state. It isn't a weakness, and we need to change that. It should be just like every other kind of physical health care. So we're on a mission to make sure that it's safe. The other thing with Charlie Health is because we're fully virtual, is you can see your clinician from the privacy of your own home. Nobody has to know. Nobody has to see your truck at the therapist's office in your little town. We want to make sure it's private and that you have access. So again, when it comes to supporting other providers on the call, however Charlie Health can do that with ripping away a stigma in Montana, we're here to do that. And then the final one and the most important is lack of behavioral health services. I'm so happy to hear about Frontier Psychiatry, you know, spreading across the state. I love to see that Shodare is expanding. They've been a wonderful partner to us. We've worked with Providence and Billings Clinic, and this is what we need as a community. We need to be collaborating and working together and expanding, because having integrated behavioral health into primary care is so necessary for the whole state, and we can't do it if we're not all succeeding. Oh. And here's another little, some statistics. So talking about more about IOP with adolescents and young adults needing mental health and addiction treatment. Again, 24/7 intake with Charlie Health. Our groups are super curated. It's one clinician to the max of 6 clients in a group. We provide clinical evaluations, all video-based services. And really at the core of who we are, we want to be a community-based service for what? Good.
Or just signaling 1 more minute left. So.
Oh, okay. Got it. So I'm going to skip ahead then. Not enough time. So anyway, mental health services are critical for teens and young adults, and Charlie Health is here. We're all virtual. We'll be forever virtual. We're in network with Blue Cross and Blue Shield. So thank you to them, and thank you to all our partners on the phone. And really, we want to support all the providers here. So however we can partner and fill a gap, please reach out to me. I'll give my information in the chat. But here's our future, right? Focus on outcomes, breaking those insurance barriers, educating the community and getting rid of stigma, and then also providing the highest quality of care. And again, Matt, thank you so much for inviting Charlie Health, and to all the partners that we work with on the line. I appreciate you, and we want to be supporting you.
Excellent. Thank you so much, Laura. We love having you in the state, and we're excited to see you grow. So
thank you.
All right. Next up, we've got Youth Dynamics. I see Dennis online. Dennis Sulzer leads Youth Dynamics, and they just do amazing work across the state of Montana for those Montana kids that we love so much. So Dennis, thanks for joining us today.
Thank you, and I'm sorry for the delay, and we'll just take a look at what we've got here. Is that you, Moira? Okay. Anyway, Youth Dynamics has been in Montana since 1981, and we began our journey here in Billings in 1981. And at that time, we actually were serving 9 children in therapeutic foster care. Last year's numbers, 2019-20, tell us that we served over 2,700 kids across the state. And if you take a look, you can see all the locations that we are serving children across the state of Montana. I'm sure that some of you are very familiar with us, but we've got offices from Kalispell to Wolf Point, Miles City to Dillon. And we just thank those that support us in each one of those communities across the state. Our mission is that we provide family-focused behavioral health treatment founded in the principles of an actively caring and trauma-sensitive culture. And we want people to realize their full potential. You can see also by this particular map, all the kids that we have served at one point in time throughout the state of Montana. Each one of those little sunshines is where we have served a youth dynamics child from the beginning in 1981. So we've made our imprint in just about every community across the state. It's really unique in that manner, and we are connected as a network of youth dynamics offices across the state of Montana. This next slide is our arrangements of services, the array that we provide. Starting at the top, you can see we have therapeutic youth group home services. We do service coordination and support, or otherwise known as case management. We have several youth mentors, upwards of 200 at any one time, that are serving kids across the state. Of course, we provide individual therapy and family therapy by our licensed clinicians. And then we also support parenting education and provide assistance for parents when they need it, whether they're therapeutic group home parents or community parents. We also have a substance use and education treatment program. Laura so aptly defined how oftentimes kids are dual diagnosed and or dealing with multiple diagnoses at the same time, including substance use diagnosis. So we really want to integrate our substance use program into our mental health behavior services. And then finally, we have what we began with, our foster care and transitional living services. This next slide just tells a little bit about our therapeutic group homes. We have therapeutic group homes in Billings, Boulder, Great Falls, and Helena. We serve kids from the age of 8 to 18. Our smaller children, the 8 to 10, 11-year-olds, are normally served in our Lewis and Clark group home in Helena. Also on the line today is Kevin Wise, and he is our clinician in charge of our residential services. Again, we really want, our expectation is that children return to their home families, and that we serve them in a way that they can return and function well within that family as they return. Therapeutic foster care. It is kind of a hybrid residential community service. Currently, Moira Anthony, who is also on the line, our clinical director of community services, she organizes the therapeutic foster care program. Right now we have well over 50 children placed across the state. And I think we have just under 100 or close to 100 licensed therapeutic foster care families. It's a program that we're continuing to look for foster care families. And it's a great program, especially in transitioning to and from the home. And oftentimes, or once in a while, it turns into an adoption. As I mentioned, our substance use program is integrated into both our therapeutic foster care programs, our therapeutic group home programs, and within our community services. We do not perform any inpatient service for substance use. It's integrated into the other services. One of the programs that we really have grown over the course, this last year is our FBS program, along with our supervised visitation. We truly believe that we would love for all children to have a stable family, and that family is reunified or can function long-term together in a permanent setting. This slide is a little bit old and dated. As I mentioned, we served almost 2,700 children this last year, but this is a basic breakdown of the services we provide and the number of kids that enjoy those services. As you see that big slice of the pie that says 2,270 children, that's our case management services. We perform case management services not only for all of the connected services within our agency, but we also perform those services for kids that are not getting direct service from us within our agency. How do we know whether or not we're doing a good job? We ask the kids. 95% of the kids tell us that they believe that YDI has had a positive impact on their lives. In addition to that, 95% of the kids we serve are underprivileged. They are what we would say at the most risk economically and otherwise. 95% of those children qualify for Medicaid services. And finally, one of the things we always ask our kids is, what do you like best about YDI? And one of our children said that the mentors that serve them say things that make my heart feel better. I'm going to turn this over to Moira. You might have to unmute yourself, Moira.
Can you guys hear me?
Now we can.
Perfect. Thank you, Dennis. Like Dennis is saying, I'm the clinical director for our community services program. I oversee all of our services that are provided in our community settings. And today I have the great honor of talking about some of our current concerns and some things that we're excited about. So right now, as everybody, I'm sure, we're concerned about maintaining the safety of our staff and our clients in COVID. That's one of our biggest concerns that we have. We are very proactive in making sure that we promote safety, but that still remains a considerate and constant concern for us. In regards to our staffing considerations for COVID, we've had therapeutic group home lockdowns where we've had to keep all of the kiddos in the group home for a 2-week span of time, and that can be very trying for our staff and for the kiddos that are locked in those homes for 14 days. So that's been difficult. Our community service offices, we've had some closures for a period of time, up to 14 days due to some COVID precautions as well. That's been some concerns that we've had. And then, of course, making sure that all of our staff are continuously able to provide all of the services that our youth and families need. And what does that look like? And so when we talk about what does our service delivery look like, and is this the new normal? We have the capacity in our infrastructure to be able to provide telehealth to all of our families. The issue is not all of our families have the ability to do telehealth. Some of them don't have internet or computers. And so some of them really struggle with being able to do telehealth as a service delivery option. So we're constantly kind of re-examining what we can do to be safe and to continue to provide these services to all of our families, regardless of what area they live in. And then things that we're really excited about happening currently at YDI. All of our community offices, even through COVID and some of the challenges we've had, provide vital services to all of our youth and families. In addition, all of our group homes are fully operational and continue to hold a very steady census. We recently had our reaccreditation for CARF. Last survey, we had a 3-year accreditation. We suspect that we'll again be given a 3-year accreditation through CARF. This is the first time that we've ever done a digitally enhanced survey through CARF, so it was all done via via technology and via Zoom and Microsoft Teams. So that was really interesting for us, but we felt that it went very well. Right now we have our Angel Tree taking place, which is our annual adoption for our youth that we have in services. This includes all of the youth we have in our community services, all youth in our therapeutic group homes, and all of our youth that are in therapeutic foster care. We're also continually being proactive in preparing for whatever potential vaccine may be coming down the pike, what that looks like for our agency, and any additional COVID precautions. I'm going to pass this now to my colleague, Kevin Wise, who is the Clinical Director for Residential Services.
Can you all hear me? Can you hear me?
Yep.
Okay, thank you. Thanks, Moira. We are going to look towards the future, and I think the future for us at one point will be no more COVID, or COVID won't be such a problem. So we're excited about that. Can I get the next slide? We're excited for the opportunities that Family First Act is going to present us with. And it aligns with all of the services that we provide to youth. We want to strengthen and improve our coordination of family engagement, discharge planning, diversion activities across all services to include the new administrative rules for case management and home support services. We are continuing to refine our trauma-informed treatment model to address youth trauma across all of our services. And that's what we have today. I would like to add that I've been a part of Youth Dynamics for about 14 years, and I think we're just bigger and better and stronger, and helping families in just such a great way. So thank you, Matt, for inviting us.
Yeah, thank you so much for the great presentation. I think that we're all looking forward to see how you and the other providers work with the Family First Act. And I mean, it's just really, really cool to see how it goes. So thank you so much for that great presentation. Next up, we have Amber Blake from Pioneer Medical Center and Catalyst. So Amber Blake from Big Timber, Montana.
Thanks, Matt. Also on the call, we have Jessica Todd, who is the high school guidance counselor here in Big Timber, who's been working with me quite closely on our project. So thank you so much for having us. So for us, we have a new nonprofit we just created called Catalyst for Change that really focuses on bringing mental health services to areas of the state that really nobody else goes to. And so just those real small towns that are kind of hard to reach. We've been running this program for a couple of years now. It did start at our high school, and we utilized telehealth often with the coordinators and the different mental health professionals that we have on the ground here to bring therapy and psychiatry and social support services to Big Timber. I'm going to let Jessica talk a little bit about kind of why this program got started, how it got started, and where we are now, and what we hope to see happen here in the future. We'll also be talking a little bit about how COVID has impacted our efforts. Go ahead, Jessica.
Hi, yeah, so I'm Jessica Todd. I'm the school counselor in Big Timber. And we, when we kind of started this, we were struggling with getting some mental health resources for our students. Also, when we've had students who were, coming back from maybe Billings, and they had been seen there, and then just trying to figure out ways to get them back to Billings or Bozeman to do resources, to get those resources that had been set up. And it wasn't feasible for parents. They would do it for maybe a little while, and then it would just kind of fall off. So we were struggling with that. And so that's kind of where the telehealth came. And we've actually been using telehealth in our school for quite a while. And it's been working really, really well. We have a room set up. The students can go in. They can get their services right at school. It relieves parent stress and student stress. And right now we're seeing a huge improvement in our students' mental health. And so it's been very, very successful. Obviously this year with COVID, we've had some more things that we've learned. Right now our students are struggling to escape from home life. Sometimes it's better at school, and so they don't have that opportunity if they're quarantined. A lot of students are experiencing a lot more anxiety through those unknowns. They're worried about things that are kind of out of their control. And then we've seen a lot of parent and staff being very overwhelmed. And Amber and I've talked before, some of that can be technology based. Some of them don't have access to the technology, and so finding ways to help that. And then another one was food and resources. So our school has set up a pantry, and that's been super important for our students during COVID.
And I think the other piece for us is that's really changed with COVID. There's been a couple things. So the one thing that's been fairly shocking to us, or at least to me, and what we're trying to do here is it seems that some of our families have really regressed kind of to just food, shelter, water, getting through day to day, where there's really not that capacity to think about mental health services or appointments and that kind of thing. It's really just, let's make sure the kids have food and clothing and a roof over their head. So that was something that maybe we didn't really see as much of before, that we have started seeing a lot of now, just kind of that really strong survival mode. Two silver linings for us that have happened since COVID is one, I would say that we were able to secure psychiatry services here locally with first-time telehealth visits. That was something that we worked on for a couple of years that we were unable to achieve, and not without great effort from local organizations like Billings Clinic or nearby organizations like Billings Clinic or the mental health centers. They've definitely gone above and beyond to try to help us get those services. And with COVID, it seems some of that red tape got cut, and we're able to secure those first-time telehealth visits. So now we have multiple providers, that are offering therapy and psychiatry, first-time visits, which has been just a game changer for us. The second piece is funding. I think the COVID funds, COVID relief funds we've been able to secure have been just astronomically helpful. I think a lot of times in these small towns, it's really difficult to secure any kind of funding, just because we don't have that population size here to, I guess, make it worth the while. Or I'm not quite sure how to explain that, but I think that us having a little more control over funds that we do get access to is unique, and that's something that's been a very welcomed gift. So I want to thank the department for helping out with that. It's really just been a lifesaver for us. I think we've probably applied for about 30 different grants probably since COVID hit. So we've definitely been all over that. And then I think just what's transpired with our program is, again, this nonprofit to just keep going and keep this program going that was originally funded by the Montana Mental Health Trust, which none of this would have been possible without them. So a huge thank you to them for giving us the opportunity to be creative and come up with this kind of pilot program that seems to be working quite well. We're going to be trying to continue that on through our nonprofit Catalyst for Change, that you can visit our website there at catalystforchange.org. You'd have to type that in the URL bar, the Google search bar. It won't work. We're still working on that. It's still pretty new. So, and then the other very exciting piece is we have one of our local representatives here who's going to help us pass a bill through the legislature for community health work, if it's at all possible. And we're trying to kind of make those things happen if we can. So that's where I'll kind of let maybe Matt step in a little bit, if he's interested at all, on speak a little more about that. That's where it kind of leaves my field. But I would say that's the overall kind of message we have. Do you have anything else you want to add, Jessica?
Amber, can you tell us a little bit about how you're using community health workers? It is a workforce that's been very important to you that I don't see utilized in other parts of the mental health system quite like you've been utilizing with your organization or the organizations that you work with.
Yeah, so the community health work that we try to really hone in on, that we're trying to kind of perfect, I guess, really has like a mental health focus, and it's really focused in these rural areas. Again, that we're really focused on going the places that a lot of people aren't going, just because we do have so many small towns in Montana. And so here in Big Timber, I think what's really been powerful is having kind of that boots on the ground person that people are familiar with here locally. And I think that's been a huge part of our success, is people, know who Jessica is, they know who I am, they know our face, they know our name. And so they're a little more willing, it seems, in these small towns to work with us than maybe outsiders. And I think that that's something worth acknowledging in small towns, is they're very tight-knit communities that are used to taking care of themselves. And, that kind of pull up your bootstraps mentality is, I think, a strength. And I know it can be a weakness too, not knowing when to ask for help. But I think the community health worker really hones in on helping people kind of maybe feel a little more comfortable with, maybe talking to someone on a screen that, people here aren't very comfortable maybe talking about their feelings to begin with, let alone on a screen to some stranger. So I think the community health worker piece is really essential in that way, that you can have as many telehealth rooms as you want in the state, but ultimately you're asking a lot of these small town folks to, jump on. I mean, some of them might not even have access to a computer or know how to use it. So we've really brought that kind of technology piece to our position too, to just kind of help people feel a little more comfortable in receiving telehealth services. So I think that's one of the strengths of our program. And Jessica, I'd be curious if you could speak a little bit to what you've seen in the school, how it's changed a little bit with the kids. Like, I think now the kids are setting up their own telehealth appointments. Is that right?
Yeah. So we've got, since we've utilized this program and we've been doing it all of last year. So this year, and through COVID, which was awesome, is our kids know how to get on to Doxy, and they have the links, and they just come in, they know when their appointments are, they come in, they go to the telehealth room, they let me know they're there, and they just get on their appointment. And so it's great, because these kids are understanding the importance of receiving these services and how much they actually have helped them. Because it can be overwhelming to have so many kids in services, but now that they see how good it is for them, they're actually, going out of their way to participate. And so it's been huge, and we've seen a lot of growth in our students. And we have students that come and want to be involved in the program and want to talk to somebody. So we have kids reaching out to us, which is different, and it's been very successful.
I think in that way, it's kind of changed the culture a bit in the school. So it's maybe not quite so taboo, or, kids maybe aren't so skittish and to getting those services, like Jessica was saying. That wasn't the case when we first started. And then I think it does kind of also have a positive impact on the families and the parents. I think that's what really has been powerful for us to see too. That's an important part of what we're doing, is the parents kind of get on board. They see their kids maybe getting better or being open to these things, so then they are too. So it's been kind of like a snowball effect in that way.
I'm sorry. We are on our final presenter for today. Thank you to Andrea McDonald of Disability Rights for being willing to present for us. Their organization has done amazing work for years.
I'm super excited to be able to share with you guys today and really tell you a little bit more about disability rights, who we are, what we're seeing across the state, and maybe some of those big picture pieces that we have. So Disability Rights Montana is a protection and advocacy agency. We are federally mandated to protect the basic human rights of people with disabilities. There is a P&A in all of the 57 states and territories. We were created in 1977. This was an act of Congress, and really their goal was that the P&As could act as an oversight agency to serve and protect people in their communities with disabilities. We are part of a national network, that's National Disability Rights Network. So when you're working with disability rights, you aren't only accessing the Montana office, but that nationwide network. So really it gives us the ability to access a greater number of resources on behalf of those clients that we're serving. Our mandate, again, is to serve those folks in Montana with disabilities by protecting their human, civil, and legal rights. And kind of unique to disability rights is this idea of our access authority. It allows us to not only monitor facilities across the state, but it gives us the ability to be in any other place where people with disabilities are served. So who does disability rights serve? Again, that goes back to anyone in the state who has a disability. This is patients or residents who are in a facility, people who are in jails or a prison, children and youth or adults in the community, anyone who's receiving those SSI or SSDI services, and then people with disability who want to vote. We also have some very specific grant funding to assist with that. I kind of like some statistics. So what we're looking at as far as the folks that disability rights serve is from August of 2019 to July of 2020. We served close to 1,300 people in 47 out of the 56 counties across the state. The most reported issues we were seeing were those of abuse, neglect, and rights violations. And the types of disabilities we were working with, that top slot fell to folks who were experiencing mental illness. We also saw several orthopedic issues, autism, and then developmental and intellectual disabilities on that list of folks that we served. Really kind of getting to the heart of, I think, why Matt asked us all to be here today is sharing what we've seen. What changes have been there since COVID-19 happened to us. And I think like much of everyone else across the state, we've had to do a significant switch in the type of work we did without being able to provide those in-person services. So we had to switch from in-person monitoring to more remote monitoring and figuring out how to do that effectively. We've had the opportunity to really begin to build some great relationships with many of our community partners. And that's been exciting for us to really reach out to places and people that we didn't always have real good communication with. Some of the positive changes that we've seen since COVID-19 happened are in facilities like the Montana State Hospital, Lewistown, or even Yellowstone Boys and Girls Ranch. They've been very transparent with us. It's been a great way to collaborate with them and to really figure out what those relationships work with and how do we work with them remotely. We're seeing facilities across the state doing the best they can with what they have. Is everything ideal? Probably not. But are we seeing providers and facilities doing the best they can for their patients and their residents? We absolutely are, and that's an exciting thing to be able to see. We've also really appreciated the ability to kind of continue doing the systemic work we do. We've had to modify what that looks like, but I think in a lot of ways, COVID has helped to draw attention to many of the values and the concerns disability rights was working on prior to COVID. It's just brought a lot more service providers to the forefront because they are seeing and experiencing those same things that we were. What about those concerns and those things that we're excited about? Some of the concerns that we're seeing without in-person monitoring, it's really challenging. Disability rights not being able to get out in the community and to facilities, and families not being able to visit their loved ones. It's a reduced number of eyes, and with that reduced oversight and people not seeing what's going on, we do have some concerns. Disability rights, we're also worried about the use of restraint and seclusion, especially with the lack of oversight that's been available since COVID started. We have some fairly significant concerns with the spread of COVID, especially in congregate care settings. So when we look at places like the Montana State Hospital, nursing homes, assisted living facilities, these settings don't really lend themselves well to the ideas of infection control. So the administrators and the service providers in these types of settings are really challenged to protect the folks that they're serving. And we've seen a lot of really great examples of how they've protected and advocated for the folks they work with, but they've also shared a ton of challenges they're seeing and how difficult it really, really is for them to be doing it. We have a lot of concerns with the out-of-state treatment or placement of Montana kids. So this kind of looks like, what effect are our Medicaid rates going to have on the placements that our kids can and can't get? Once we send those kiddos out of state, what oversight do they actually have, and how are we making sure that they're protected? And then our concern that's always been a little bit underlying, and I think a lot of folks today have touched on that, are what do community services look like, especially adequate crisis diversion services? How do we keep folks out of facilities and in the community and healthy while we're doing that? One of the examples we saw as COVID started was an increase in facility admissions. And that was really challenging, especially for a system that was already kind of taxed and struggling to make sure that they had the staffing they needed. And that leads right into the staffing concerns that we're seeing and we're having providers express to us as we're monitoring. They're challenged to find enough folks to work. And when they do have enough folks to work, keeping them out of quarantine and actually they're providing services for them. The types of things we're really excited about and we're seeing across the state is really the ability for not just disability rights, but agencies to begin partnering in a way that they weren't prior to COVID. We're seeing a frankness and an openness that in collaborations that weren't always there. And that's really nice to start seeing. And I think has opened up some really great discussions that may not have been happening before. We're also having really great discussions, and it's beginning to address some concerns and services. So specifically, disability rights has been able to participate in some work groups that are seeing a shift to maybe some person-centered approaches, especially in policy work like SB 5 and the Big Sky Waiver. So it's nice to be able to see that thought process changing and it being reflected in the policies that are there for those services. So keeping it kind of nice and concise at the very end of the day, I think we've all gotten some fantastic information, and I so appreciate Matt being able to put this all together for us so we can each see what the other group is doing. I just want to leave you with the ability to contact disability rights. If you do have further questions or concerns, anyone can call disability rights. If you have a disability or have a concern on behalf of a person with a disability, you can always call and ask us questions. You can report a complaint. Calls to us can be anonymous, and we're always happy to hear from you and to be able to assist you, even if it's just pointing you in the right direction, like some of those providers that we've gotten to hear from today. So thanks so much, Matt, for letting us speak.
Andrea, thank you. That was really wonderful. It was great to be able to hear how you and your team are working. I also want to say thanks to Bernadette Franks Ongoy, who is on the call, who leads disability rights, and Beth Brenneman, who is their lobbyist and is one of the absolute best lobbyists in the mental health space. Everybody who works on mental health in Montana has benefited from Beth's amazing work at the legislature. So that is all that we have for today. I'm really so grateful to everybody that has presented and has tuned in. I hope you got what I felt like I got out of it was an amazing snapshot of all of these different organizations and how they're working with the current challenges and working to care for Montanans in the future. So we're so absolutely grateful. We will post the video of this on our website. We will also have a transcript done. So people that can't watch the video can do the transcript. And we will have continuing education credits available for free. You'll have your certificates emailed to you if you selected that in your Zoom participation. So thanks again for Tim Lewis with Montana Interactive. Tim provided all the IT and the communications for this, and we absolutely could not have done this without Tim. And for the Addictive and Mental Disorders Division that sponsors the Montana Conference on Mental Illness and this webinar series, which is replacing it this year. Please remember that Dr. John Mann is presenting on December 22nd at noon, and he is an amazing suicide prevention researcher. Don't miss that, and especially for those of you that need suicide prevention credit CEUs. So thanks again for everyone's for coming out for today. Have a great rest of the week.